Welcome to your Metro Atlanta EMS Academy lecture series. This presentation, Mother and Child, was recorded in April of 2022 at Metro Atlanta EMS Academy headquarters in Marietta, Georgia, with the recruits of EMT Cohort number 18, and is presented by EMT Instructor David Peavy and Paramedic Michael Patterson. Mike has almost 10 years of EMS field experience, including work on Children's Healthcare of Atlanta's critical care ground transport. Mike earned his spot on CHOA's Neonatal ICU team after several years as a paramedic in the CHOA Eggleston Emergency Department. As of this recording, Mike flies with Air Methods out of Covington, Georgia, and works PRN with Metro Atlanta on Cobb and Bartow County 911 services. Mike frequently contributes to EMS instruction at the EMS Academy and at Emory University. The Mother and Child presentation covers material from Emergency Care and Transportation of the Sick and Injured, 12th edition, Chapter 24, Gynecological Emergencies, Chapter 34, Obstetrics and Neonatal Care, to include obstetrical emergencies, delivery complications, neonatal resuscitation, and Chapter 35, Pediatric Emergencies.
I spent 2.5 years on CHOA's critical care transports. That's kind of where I've got my wheelhouse is in peds. A lot of the information that's included in the gynecologic emergencies are going to be a lot of common knowledge. Some of it is not. If you're unfamiliar with some of it, that's totally okay. But there's not going to be a whole lot that we have to do with gynecologic emergencies besides massive hemorrhage. OB is going to be like precipitous childbirth. And let's see, those are going to be the main things that we're going to be concerned about as EMTs with our gynecological emergencies. Sexual assault, while it is not an emergency typically, it is something that we need to be very concerned about because we need to treat the patient well. They've just had a very traumatic experience. It's really tough to have to deal with that personally if you have a history of something like that. There is a slide in here that gives us a figure on the number of females have been sexually assaulted. And it's an unfortunate fact, but true. So that does happen to folks.
And I would add to Mike's comment on managing sexual assault patients. The stats you're all going to see are those that obviously are reported. Yeah.
Yeah, there's plenty of them that definitely go unreported. Partner violence is a huge thing that often does not get reported because of the psychological implications of, hey, this is the person that I'm with, or I'm afraid of the person I'm with, or just different things of that nature. So yep, we're going to talk about vaginal bleeding, all those things leading up to the vaginal bleed, sexual assault, infections. Infections usually are not the emergency unless they've been sitting there cooking for a long time. Just gotta worry about shock with our vaginal bleeding. You guys all know about that. You're gonna have pallor, tachycardia, possibly altered mentation. It's pretty obvious that women are made differently than men. Yeah, surprise, I bet. So they are designed to carry babies and make babies for us. There are obvious parts of the female external genitalia. If you're not familiar with it, that's it right there. The one part I will talk about is the perineum. Right here is the space in between the vagina and the anus. That has a tendency to rip during delivery, childbirth. So that's an area that you actually want to support. You kind of like press in just a little bit, and then the baby will kind of right there into your hand. If you have a unsupported precipitous delivery kind of situation, you will tear there. And it's not uncommon if it does happen It's not your fault sometimes. It's just the force of the baby, the connectivity of the individual, like their tissues, how elastic they are, things like that. Typically what they'll do, they'll go and they'll just sew you up. So make you good as new. But that could be a source of bleeding when we do a home birth. Basic anatomy. So you've got ovaries, which are the gonads for females, the converse, obverse, whatever, for men, testes. Yeah. The fallopian tubes connect with those ovaries to the uterus. So big old muscle, and it's kind of where the child develops, the fetus develops. Until contractions happen, until delivery, you'll feel those contractions when the person is delivering. So, let's see. There is our anatomy. So, your uterus is actually anti-flexed, so it's pitched forwards towards your belly button. One of the things that they talk about with after delivery is uterine massage. So it's one of these things that you can actually really help that mother after she's delivered, because there is going to be some uterine acne. They've already expended all that effort trying to push that baby out, and then your uterus is a little bit kind of stunned or tired. You go ahead, you take your fist and you grind into their stomach. Unfortunately, it is very painful, but it can keep them from bleeding out. If you got that uterus that has been working, and it will sustain just a little bit of trauma from pushing that baby through. You will bleed a little bit, but if they've got that big floppy uterus that is not tightening down the way that it should due to the hormones and everything, you can give it a little bit of help with that uterine massage. This is what I was talking about. So ovary, fallopian tube, uterus, cervix, the very most superior part of your vagina. And then this would be the vaginal opening right there, pelvic bone, and then these guys right there are going to be your intestines, spine, subcu fat. Let's see, so as we may know, ovulation begins in teenage years. So when you get to puberty, you'll start menstruation. It's also known as menarche. That's your first period. Typically around 11, sometimes to 16. Everybody's different. There's no set point where it's like, oh my God, I haven't gotten there yet. We'll touch a little bit on that when we get to the pediatrics, because it can be a sensitive subject for them. Let's see. So unfortunately, you have to deal with that pretty much monthly until you're in your mid to late 40s, unless you use some kind of contraception that prevents you from having periods. There are multiple different forms of contraception. I'm sure you guys are familiar. So, wonderful thing about getting up to menopause, once you're done with it, you're done with it. The unfortunate part is when you're getting on to menopause is that you've got those hot flashes, mood swings, stuff like that. It's just not fun. So yeah, you get one egg typically per menstruation. And it's funny because it alternates between which ovary it comes from. So if you've only got that one ovary, you may end up getting just, one egg every other month. So some people will have, either through a birth defect or they get an infection or something like that, they have to have one taken out. So. Something that I didn't know way before was I thought that fertilization happened actually like in the uterus, rather than sperm will go through the cervix, travel up through the uterus, go all the way to the fallopian tubes. That's where you get fertilization to happen. Then it'll travel and then implant into the uterine wall. That's where you actually get the place where it latches on, gets its blood supply. You start with the the sac and everything like that. One of the things that can happen with being matched up sperm and egg all the way up in the fallopian tube is an ectopic pregnancy. So that would be a pregnancy that implants anywhere other than the uterus. So it doesn't always have to be just the fallopian tubes. It could be strange enough to where it happens intra-abdominally.
Right, and to add to that, one of the misconceptions I had prior to my training was that the uterus was designed to nurture and grow the baby. Incorrect. Uterus exists and is evolved for one purpose: eject the baby, to evict, as it were. As Mike was saying, yeah, that ovum can attach to anywhere in the body, and anywhere other than the uterus can be from dangerous to catastrophic.
So that could be another reason why you could only have, like one working ovary anymore, because, you have an ectopic, then they have to go ahead and evacuate that that extra uterine pregnancy, and then so you've only got one functioning ovary at that point. Ectopic pregnancies can be a surgical emergency, a gynecological OB emergency, if it is ruptured. So what we talk about is any kind of abdominal pain in a female that is of childbearing age is ectopic until proven otherwise. That's just an easy way to go about it, because you don't want to be the guy that rolls in and says, oh yeah, you know what, I think she's got appendicitis, and then she's actually bleeding internally and she dies. That's going to suck. If you don't get fertilization of an egg, then it sheds all the uterine lining. It's also known as a period. Comes along with a lot of great symptoms. Personally, I haven't had to deal with them, so I won't even go in and pretend that I know what it's like. All right, PID. It's an annoying one. It's pretty prevalent. Again, it's not really one of the emergencies that we're going to be super concerned about, but it does cause a lot of distress to your patient. So that's something that you do actually want to be concerned about. There are lots of different ways to help it. A lot of times it is due to sexually transmitted infections, STIs. I don't know if there's anybody who's old enough who we used to call them STDs. The slide still says STDs, but the common vernacular is STI now. With PID, it's related to a bacterial infection, occurs almost exclusively in sexually active women. So if this infection expands and stays for an extended period of time in the fallopian tube, it'll cause scarring, it can cause infertility. So it's just not a fun thing. If your patient has any kind of symptom associated with an STI, be it rash, discharge, abdominal pain, fever, all those kinds of things, encourage them to get regular testing, use protection, and then get treatment. Simple things that we may think about as normal, but our patient population may not. Yes?
Can it also be caused by a woman leaving their tampons?
I don't know specifically.
Because I've heard that.
Okay. I wouldn't be surprised, because if you do leave your tampon in for too long, then that could lead to bacterial vaginosis. Then that leads to your PID. Mm-hmm. So I wouldn't be surprised with that one at all.
There's another syndrome that comes along with that could probably cause that too. So
Yes.
Toxic shock.
The shock, yeah.
Yeah,
like
toxic
TSS,
shock
yeah.
syndrome. Yeah. I had a patient down at the Braves game a week ago, and she was super concerned for TSS because she had just switched from using tampons and went to pads, and then she had a syncopal episode and she was feeling weak, and I was like, you're good. Like, blood pressure is a little high right now, in fact. You look just a little pale, but, not like shocky. You got good perfusion. So that was just a whole lot of coaching, encouraging, and treating the psychological part of her quote unquote gynecological emergency. She was just having a heavy mens, you know. That's kind of what it was. She needed to drink up her water and to take it easy. Oh, on the notes here, it does say that, yeah, if you leave this PID untreated, depending on which infection it is, could cause abscess. Then that leads to a whole lot of other bad things. You might even have to have a hysterectomy, and that would suck. If you're a young person who wanted to have kids at one point and just left an STI untreated, then you lose the chance of having your own children if that's something you wanted. So just encourage your patients to do regular screenings and checkups, and if they have some weird things, go get it evaluated. So here it is, STDs, but STIs. Such as PID, pelvic inflammatory disease. Chlamydia being your most common. It's a bacterial infection. Go to your doctor, get antibiotics. It should clear up, no problem. Again, this is the other thing of just routine screenings, treatment, protection. BV bacterial vaginosis. As you see, it's the most common most common vaginal infection. Usually ages 15 to 44, and then untreated could lead you to the premature birth, low birth weight, early rupture of membranes. Gonorrhea, that's another bacterial one. It can travel all through the reproductive area. It's another nasty guy that, you know what, again, we're going to want treatment, we're going to want early detection, protection. So.
I also have a question. If there's a situation where a woman is giving birth, are any of these going to directly affect the baby whenever?
So things that can affect the child would be things like Group B strep, an active herpes outbreak. So those can easily be transmitted to the child just through, contact. You're in that mucous membrane, as that child is coming through. So that's one of the things. Bacterial infections are going to be problematic for the mother, not so much the child, because you're already at a weakened state. So you're going to want to treat her with antibiotics like right away, IV antibiotics rather than, oral, because they'll be quicker and more effective.
Is there anything that we do to help address those for
Nope.
the baby?
Nah. The things that we do, report it to the clinician that you hand off to. You say, hey, you know what? Mom was Group B positive at her last exam. She didn't get treatment for it at that time. Then they do with it what they will.
Okay.
You say she's having an active herpes outbreak, and then they will treat it with antivirals. So
gonorrhea or chlamydia don't affect the child while giving birth?
they typically won't, but I mean, so if you got that active infection, they want you to be on antibiotics, Typically, you're not going to get those during your pregnancy, but it's possible. Depends on who you're sleeping with and who that person is sleeping with, It's one of those 6 degrees of separation where if the individual that you are having sex with is having sex with somebody else, they can pass it right on to you during that pregnancy. Hopefully that's not the situation. So if it does enter the bloodstream, it can provide overwhelming sepsis. You're going to know that this person's sick when you walk in the door. You're not going to know why they're sick, and on your differential field diagnosis, I can guarantee you that bacterial vaginosis, gonorrhea are going to be pretty low on your list of things, even though that might be the culprit when they finally figure it out. For us, it would be treating shock, rapid transport, maybe an ALS intercept, depending on where you're located. Here in Metro Atlanta, it's pretty easy to get to the hospital within 15 minutes. So an ALS intercept is kind of moot at that point. So different causes for vaginal bleeding here. That is actually going to be a pretty, not typical, but not abnormal call for you guys to go on. You're going to have somebody who says, hey, I'm spotting more than usual, or I'm bleeding more. Yes, I'm on my period, but this is a lot more than I'm used to.
I would dare say you'll get that call, from my experience working Cobb County 911, couple of times a month, couple of 3 times a month, you'll get that call, and maybe a couple of 3 times a year, it's actually serious bleeding to almost like that you really have to intervene upon in the field.
Right. Most of the times with these kinds of issues, your history is going to be the most important part, because, you know, as a male or even as a female, that's a sensitive topic to have to do a physical exam on. And if it is not absolutely critical, then it's not critical, okay? If they are bleeding and say, you know, hey, they're saturating their clothing, you're like, yeah, I need to know whether it's an internal bleed or an external bleed. If it's external, I can put direct pressure on it. Hey, I can solve the problem. If it's internal, there's not much we can do about that besides rapid transport to where they have surgical suites and blood products. Get them to the hospital, provide early notification. So these different causes for vaginal bleeding, like I was talking about the ectopic, that is going to be like a ruptured ectopic, is going to be a life-threatening emergency. Spontaneous abortion is going to be one that could be both a physical and psychological emergency. Those are never fun to deal with. I thankfully have not had to do one, but I've heard from plenty of my colleagues about, you know, finding fetal products in a toilet. That's not uncommon because the individual thinks that they feel as though they have to have a bowel movement, and then they realize that they have passed fetal tissue, then they'll call 911. And with that one, Dave, you know, you bring the tissue with you.
It all goes to the hospital.
Yeah. So
So you have to fish it out of the toilet?
we've got an OB kit that should have a plastic bag in it. And yes, so you've got PPE and everything, and it's an unfortunate thing that we'll have to deal with. And that individual really needs psychological first aid, you know. You think about this one is that they actually may not have wanted that child either, you know. So you got to think of it both sides. And so you can't just go in assuming that, hey, they've lost this product that they wanted. They may be, you know, kind of happy about the fact that they've had a miscarriage.
They may indeed have been unaware.
There's that one too. You know that show, I Didn't Know I Was Pregnant? So there's that one. Cervical polyps and cancer, those can cause abnormal discharge, bleeding, etc. You're not going to know that one from an external exam. That's one of those ones where you say, okay, well, let's get you to somebody who knows a lot more. They have better tests than we do. Some of the tests that they can perform are blood work. You can do imaging via ultrasound. So that would just be the sound waves are creating an image after it's reflecting off of whatever tissue is inside the uterus or in the lower abdomen / pelvic area. Okay, so patient assessment. So getting your history is going to be the most important thing because they are the ones who are inside their body. They can tell you about what's been going on lately, how this is regular or not regular, and your questions are going to help lead to the investigation of kind of like what's going on. Sick versus not sick. So that's going to be an easy one where, you know, you come in, it's from the doorway assessment is what I call it. You know, I walk in from the front door and I look at Dave and I go, oh, he's got rosy cheeks. He's looking at me. You know, if I asked him his name, he'd be able to respond to me. Cool, we're doing all right. Or, you know, there's obviously somebody who you walk in, they're pale, they're not really registering you as you walk in. and you know, they just look like crap. Let's see. So the important part for your gynecologic emergency, say for instance your sexual assault or whatever, your size up is going to be really big. Scene safety. If you're getting dispatched to a vaginal bleed, you just want to have it in the back of your mind that, oh, this could be some kind of trauma. You don't know if the assailant is still on scene, if it is that person who is in the corner who is controlling the individual, say, you know, for, and maybe even sex trade, you know. There's apparently a lot of that here in Metro Atlanta because I-20 goes east and west, and apparently they traffic them on the big semis. So, had no idea until I started working at Ch24 that that's a huge thing here. Let's see. So your size up. Is your scene safe? Do you need backup? Do you need police assistance? The scene will tell you some of those context clues, i.e., you know, hey, do you see like the house is in disarray, as in there's been a physical altercation? If so, like, all right, guys, there's some equipment from the truck I'm going to need for this one. Evacuate yourself, call for backup. And there's nothing wrong with going, this doesn't feel right, I'm out. You don't have to provide an excuse or anything. Let's see. So your basic scene size up of, you know, how many patients, what resources do I need? Are we big sick, little sick? And your PPE is going to be big on this one. You know, we always say BSI scene safe. This one, I'm probably going to, if I'm going into more for the OB, as in like, you know, face shield, gown, mask, gloves, all the stuff. For somebody who's bleeding, I'd probably want to have like eye protection and gloves, maybe a mask. So this one says, in sexual assault, it's important to have a female EMT provide care. I'm going to disagree with the book on this one, just because I don't think it takes into consideration the different relationships that can occur. So if you are a female that has been assaulted by a female, you may not want another female in the back of the truck. Maybe you want a male. It just depends on who you connect with. So if there is a male-male crew and just one of you guys gets along better with the patient or something, and they like kind of, you can feel that kind of dynamic. Like, hey man, I'm gonna tech this call. Cool, sounds good to me. Don't tell anybody that I've ever done this one, because medics always have to tech our calls here on the 911 system. But there is something in our policy about, hey, if it is a female, like a behavioral psychological emergency, it's okay to have, you know, the same gender tech the call. So I have had my EMT ride the back with a female, kind of like that needs that emotional support, whether it be from psychological trauma, physical trauma, whatever. And conversely, it's been the same way. You know, if, you know, say I was on a medic crew with a female, and, you know, there was somebody of the same gender or opposite, and they and I got along better. Saying, all right, man, I know it's your turn to tech it, but I'll run this one. And that's just something you feel out.
Kevin.
Yes, sir.
So specifically as a guy, when you are trying to, what is the whole, how do you broach examine the patient for vaginal bleeding? You were saying, like, do you not examine, or do you, unless it's overwhelming?
Yeah, with that one, I'm gonna rely heavily on my what they call HPI, history physical exam. What I want to do is I want to ask them a lot of questions first before we actually get to something with hands-on. Even as much as feeling their wrist for a pulse could be shocking to this individual if they've been assaulted. So I'm going to keep my distance. I'm going to talk to them a whole lot, use a reassuring voice, not give them too many commands or anything, but, you know, I'm just speak to you softly. I just kind of want to understand what's going on. but I do have a couple of questions that might be uncomfortable for you. Are you okay with that? Asking for consent is going to be huge in this situation. So I'm going to ask, how long have you been bleeding? How many pads are you going through per hour? If they say, I can't even count, and you're like, well, I know this is going to be uncomfortable, but I do need to provide an external examination to kind of see where this bleeding is coming from and see if there's anything I can do right now before we go to the hospital or on the way to the hospital. Typically, they'll be able to help you with that one. It's just a touchy subject. But yeah, a lot of history taking is going to be the important part on that one.
And then what about in that regard with pediatrics? And I guess it gets kind of touchy where if you suspect, if there's bleeding there and there's a parent there, you obviously want to have the parent involved.
So
unless
if
you
it's
feel
like,
the parent makes you feel awkward, you know what I'm saying?
if it's like the first time having a period, they probably told their parent that, hey, something's going on. And typically they won't be calling 911 for that one, but they may, and it all depends on, what their level of understanding is of that whole process. So with the pediatric patient, you can address the parent, you can address the patient in those kind of situations. If you believe it's kind of an assault situation and you're getting a weird vibe, you might want to separate. You say, hey mom, I understand this is your baby. Hey dad, I understand this is your child. But I do need to ask them some personal questions separately for 1 second, then I'll bring you back in. At that point, I bring them into my ambulance. I have somebody else with me, either police or my partner. Police preferably because they have body cam. So if this patient then makes a claim that, hey, you know what, that EMT assaulted me, hey, you know what, there's a record. I didn't do anything inappropriate.
I would like to add there, though, any injury, bleeding, trauma to a pediatrics genital area is a prime indicator of. Absolutely. And at that point, you should have PD en route and just be prepared to satisfy that reporting requirement.
One thing that is going to be a caveat to that, because there's always exceptions to the rule.
Right.
Straddle injuries. So those happen. You know what? Hey, I was on the monkey bars and then my feet slipped and I went right onto my privates. So that can cause internal and external bleeding for females. And we'll see those plenty over at CHOA. The story's going to match up. So you're not going to get that weird spidey sense tingling. Things are going to sound normal, and the parent is going to have the same story as the kid. So that one you don't really need to be concerned about as much about, except if there is that, that massive hemorrhage kind of situation. Hopefully that gets you satisfied with that question.
Yeah, no, having a police, even if they're just standing, I wouldn't want them facing,
Absolutely, yeah.
But having them in the back watching, like you said, their
The
body
thing I
cam.
said about the body cam too, is you can always say, hey, can you record my questioning? And he can stand at the side door while you're doing whatever you
Yeah, they don't even need to be focused on you, because it's going to record audio too.
It's going to record everything you say.
Okay, so mechanism of injury, they'll say has been assaulted. You don't know if that's, big sick, little sick until you get there. But if there is assault anywhere in the title of your dispatch, PD en route, hey, you know what? We're in stage for this one. Even if dispatch doesn't tell you to stage, you have that option, y'all. Let's get into your primary. Sick, not sick. Big sick, little sick. Stable, unstable. All sorts of different ways of saying load and go or stay and play. It says use the APGAR scale, but you should be able to decipher that stuff pretty immediately from the doorway. You go, okay, they're looking at me, they're tracking. I say hello to them, they say hi back. If you have to go anywhere further down that APGAR, then they're big sick. And they require intervention immediately. Do your ABCs. Your circulation is going to be the biggest one when we're talking about blood loss. So you're looking for skin color, condition, temperature, your pulses, and there you go. Most gynecologic emergencies are not life-threatening. But there you go. As well, if they're shocky, get them going quick. It gets to history taking that we've kind of touched on already. So these questions can be extremely personal. You need to make sure that they are in a private space. I really like, for any kind of emergency, to be in my ambulance. In the back of the truck, that's my office. That's where I feel comfortable. That's where all my stuff is, you know? The jump kit and the stretcher with oxygen and my monitor, that's just a tiny little portion of the equipment that is afforded to me. In the back of my truck is where I got all my toys. So I'm gonna bring the patient to my play spot, you know, my office, if I'm able to. If they need immediate resuscitation, then we're gonna do it right there. But if they are stable enough to get to the truck, that's where I really wanna be, because that's also what'll get us to the place that we really need to be. Our final destination at the hospital. Yes, being sensitive to these, you know, private questions and personal knowledge. Put them in your office, you know? You can consider this kind of like your quote-unquote doctor's office.
Yeah, that is your comfort zone.
Yeah. This is where you can shut the doors and you can have a frank and honest conversation. If you're on scene with somebody who's been assaulted, maybe the assailant is still there, but they don't feel comfortable talking about it in their living room. You say, hey, you know what? We're going to get you into the ambulance and we're going to head on to the hospital. And you can usually do, if they're stable, you can do this exam, this history taking on your way. And that way you kind of separate them from the scene of whatever may have happened. So that physical separation can help them psychologically. Additionally, you may be getting them away from the assailant, and you're providing that privacy so that you can ask those personal questions.
I would add the caveat, though, if it's the scene where you show up and there's crowning occurring.
Oh,
yeah.
Yeah,
we're not going to the office yet.
No, that's a different story. Yeah, if there's a precipitous delivery, you make your office right where they are. So. As far as abdominal pain is concerned, it's where you get into your OPQRST kind of situation. So those are going to be your clues that you can provide to the nurse or physician at the receiving hospital. That's really going to help them and fast track their assessment. They're obviously going to do their own history and exam, but if you give them some of your details that you've gleaned from the interview, then it can help them kind of move along. You say, hey, you know what, they've got a history of PID, they're having the same symptoms again, it's lower abdominal pain, it's rated at a 6 out of 10, it's cramping in nature, it comes and goes. They last had a bowel movement yesterday, they are on this kind of birth control. They, just run through whatever you have learned, and it gives them an idea. Kind of your OPQRST stuff. Quantity, so they talk about number of pads that have been saturated. That's going to be a big one, or towels or whatever, get a report of that and then provide that information to the physician or the nurse. Your sample history, what kind of birth control they may or may not be using, the last menstrual period, any kind of medical conditions, as in, hey, you know what, when I was 22, I actually had an ectopic, it was in my right fallopian, and they had to do surgery and remove that side. So I've only got the left ovary now. Cool. That is awesome to know. Well, not cool, but great. Thank you for telling me that. I'll make sure that the provider is notified. This is going to be your general assessment on your secondary, where we're focusing in on that area of your lower abdomen and your genitals. We're talking about with visible bleeding, going to be that external. You know, if you have that internal bleeding that is then coming external, we're not going to be able to tell the source at that point. Neuro, if they are at all not oriented, alert ×4, then we've got a problem. That's going to be an immediate transport. Okay, so for your abdomen, your general abdomen exam, you know, are they tender? Are they guarding? Do they have rebound tenderness? Are they distended? Do they have bowel sounds? You know, all these things can tell us a little bit more about what's going on inside, because we don't have x-ray vision, we don't have imaging, we don't have those kinds of things in the back of the truck. We're going to rely on our physical. Only examine the external genital if necessary. Again, a lot of it's going to be your history taking, not so much your physical. If you do have to do an external exam, just explain it. Say, hey, this is why we need to do it. Are you okay with that? If they say no, you can't do anything about it. Because then if you go ahead and do it, that can be assault and battery. We don't want that, especially dealing with somebody who has sexual trauma, because then you get that sexual assault and battery, and then you're going to have a hard time working. Your older patients, they can have issues too. So once you do get to menopause, a lot of them will actually go on HRT, hormone replacement therapy. So there are certain conditions that can be affected by that. Less likely to have a bleeding kind of emergency. Might be like a pain, discomfort. One of the things that can often happen with women, if they have children who have a large birth weight, is going to be urinary incontinence. That causes them some embarrassment. It's totally normal. My ma even has it, like, so she tinkles a little bit if she gets excited. So, hey, you know what? It's all good. We're humans. This is what we do. We excrete things. It's totally okay. Some might feel super embarrassed about that, but it's like, it's totally okay. I don't mind it. I'm sorry that this happens to you. Let's see. So pelvic floor collapse is going to be one of those things that we're not going to be able to tell from the external. Let's see.
So I have a question.
Go ahead.
With sexual assault, if they're complaining of pain,
Mhm.
is pain medicine going to be given, or are you going to try to hold off to use the hospital?
Depends on your protocols. So, per Metro, I can't give anything for that. I can call the physician and say, hey, you know what? I have somebody who's been assaulted. I may or may not say it was sexual in nature. I would say I have somebody who's been assaulted. They have external genital trauma. That's probably what I would express to them. And I say, I'm requesting XYZ medication for yada, yada, yada. Just give them the whole radio report so that then they can make that decision. So the best thing is to always bump it up to somebody above your level. You know what? Don't take all the responsibility. Whether it is talking to your supervisor, having your instructor, or the physician,
To add on to that question, an excellent question, I would think I would ask, given that radio report, for 2.5 IV Versed before I would go to a narcotic analgesic or even ketamine.
Yeah, that's not a bad idea.
Something to chill out.
Yeah,
Because if you've got that trauma, that psychological, both physical and psychological, you might want a benzo to kind of just mellow the mood a
Yeah.
little bit.
And I would tend to think, given our Metro relationship with our primary receiving facility, Kennestone or Cobb, you'd probably be a little more likely to get a yes on 2.5 of Versed versus breaking into the fentanyl or the ketamine, which may not even be appropriate given the nature of the trauma.
There is that, yeah. I mean, once they get to the hospital, they might just say, hey, you know what? We're going to just give them some Toradol.
Yeah.
One of the things you can do for pain control is we've got ice packs.
Yep.
You know what? Like, so that might be a little uncomfortable initially, but that can provide, you know, pain control, swelling, bleeding control, that kind of stuff. So that's a BLS intervention that we can all do.
Here, here. And what was your follow-up question?
So the other question is, if you have somebody that is an older person that's having some extreme vaginal bleeding, and they're on a blood thinner like Coumadin or anything like that, are you going to see a difference in the blood? Like, is it going to look more liquidy or?
Nah, it's bright red, dark red, or a combination thereof.
Yeah.
Just depending on the locus of the bleed. And older female patient with, or it doesn't even necessarily have to be older, but any female patient with a vaginal bleed that does take a blood thinner. I think the youngest patient I've ever had, that epistaxis report I played for y'all, she's 43 and on Coumadin. Yeah, that's one you're going to want to stay well ahead of because you can collect a lot of blood in spaces that aren't easy to see externally.
And so getting them rapid transport to a place where they can handle that is going to be important. Number one, they've got blood products. Number two, there are certain medications that can reverse blood thinners. So they have those kinds of things. And if it's a surgical emergency, they've got that too. So rapid transport is indicated for those kinds of people. Okay. Smart question. Observe for vaginal discharge? No, thank you. I'm not doing that. I'm just going to ask about it. I'm going to say, hey, do you have any abnormal discharge? Is it foul smelling? What does it look like? You know, just asking those follow-up questions.
Yeah, I think we can go back to retouching on Chris's question, and this would be for male and female providers as well. Job one, advocate for our patient. Job two, protect our patient's dignity, particularly when what they're going through is profoundly undignified. In absence of any immediate life threat, and I'm 8 to 10 minutes away from the hospital, I'm not looking at another patient's genitals.
I can tell one time that I had to look at a patient's genitals that was non-OB kind of situation.
Yeah, immediate life threat or delivering a baby. You know.
It was a male. He was complaining about swelling to his testicles. And so that can be a surgical emergency if you have testicular torsion. So I was like, hey man, I'm sorry, but I've got to do an exam. We just lowered your shorts for me. I had a sheet over top of them, looked at them. They looked normal to me. Nothing was like blue, swollen, anything like that. I said, cool, that's all I needed to do. We're going to head on to the hospital. So yeah, 1 year, or one time in 7 years of being a medic. These key indicators right here, if you've got those, you've got a sick patient. So fever is going to be a big one. Nausea and vomiting often comes with infection as well. So those are the ones that you want to rapidly transport, provide a good report. You know, they talk about SBAR in the hospital. And the last bit of that is so situation background assessment recommendations. The R is going to be one that's important. You say, hey man, I have suspicion that it is infection. I recommend antibiotics. You know, something like that. Let's see. So your vital signs is going to be your normal stuff. Considering orthostatics, if I've got somebody who is bleeding profoundly, I'm not going to try to do orthostatics on them. My first thing about orthostatics is, hey, are you dizzy? Do you feel lightheaded? Yes, you're positive for orthostatic hypotension. Because if you are laying flat and you feel that way, your BP is in the crapper. Rapid transport. If you get them flat, take their BP and it's okay, cool. You get them to sitting up, and as you sit them up, they go, ooh, cool, your positive. Don't need to do anything else. I'm not going to stand you up at one point to then get a BP and heart rate. If you've got an NIBP machine, it's awesome because you don't have to do a manual. You don't have to auscultate as many times. This one right here, so your external vaginal bleeding, so direct pressure. It doesn't have to be a moist, sterile dressing. It's better if it can be, because that way it won't stick as much to the site of the bleed when you go to remove it, or not when we go to remove it, but when the hospital staff goes to remove it. Do not place anything inside the vagina. Don't do it. If they are bleeding from the vagina, what you can do is you put a pad there and you note how many they saturate during your time. Again, that could be a sexual assault kind of situation. The only time that you'll ever do that is if there is an obstetrical emergency, you've got a gloved hand and you are providing a relief on that umbilical cord for that child to receive blood and oxygen. That'll be the only time that you're supposed to put a gloved hand inside.
Or protecting airway on a breech.
Yeah.
That's entirely.
Same situation.
Yeah, extremely rare.
1 in 5 women has reported being raped. So we can assume that number is higher. It's an unfortunate fact. You know somebody in your life who's been assaulted. That bothers the hell out of me, but that's a different situation. You can just provide psychological first aid. And I'll advocate for therapy every single day of my life.
You're here.
It's good stuff. Let's move on. There you go. Be nice to them. Treat them with respect. Put them in a private area. You've got that option of going with somebody of the opposite gender. There are medications and pharmaceuticals that are used to facilitate sexual assault. All these hospitals that we transport to will have a SANE nurse available. They may not be there 24/7, but they can call in that person. They're always on call. So any hospital, any ED can take care of them. No, I knew that we don't get exposed to them much in the field. And I didn't want to be that one on scene that is freaking out, because that's what happens so often with pre-hospital providers. They're like, oh my God, it's a kid. It'll be okay. You just got to get used to it. I mean, like the first time that you ever start an IV or do a patient assessment, you're not used to it, So exposing yourself to that kind of stuff gets you more comfortable with it. So that was my whole thing. I wanted to be that person on scene that can go, all right, cool, I got this. While everybody else is freaking out. Because, think about it. When you come on scene and the parents are hyped because this is their baby, then you've got your fire crew, your police officers, everybody around who's also hyped. You want to be that calm in the storm. You say, hey, you know what? I got this. Even if I like to think of you're like a duck, on top of the water, calm, smooth, whatever. Underneath the water, you're paddling like hell. So don't let them see you sweat. Alrighty, so we're gonna go straight from our gynecological emergencies into OB. Most deliveries do occur in the hospital, especially if you're a high-risk individual. They're going to throw you into the hospital a week, 2 weeks before. You're going to be on bed rest anyways, and they'll admit you early on in that whole situation. You're going to be seeing the doctor weekly, if not multiple times in a week. So sometimes people do elect to have their baby at home. It's becoming more and more prevalent with doulas and midwives and all that kind of stuff. These are going to be the ones that we're called to. You know what? Because there's a problem with the home birth. So those are the scariest ones. The uncomplicated delivery, where it's just like, okay, yeah, it came a little bit more quickly than I expected. I'm going. You know, that's typically, a healthy baby, a healthy mom. They've already had kids before, because if it's your first birth, you're probably gonna be in labor for a little while. If this kid comes a little bit more quickly than you were expecting to, it's probably because you've had a couple children already. So typically, women are able to take care of that whole birthing process themselves. The couple that I have been on scene for have been super simple, uncomplicated deliveries, and mom took care of everything, and then I just did clamp, cut. Took care of the baby. Mom was fine afterwards, baby was doing great. APGAR is above 7, I'm happy. The ones that are more complicated are, even right now, I would probably be pissing myself, to be honest. Yes?
Well, I'd like to throw in, you have some providers out there, and some of y'all have heard this a little bit before, but there are many providers out there that take a nonchalant attitude towards childbirth in the field, that, for millions of years, hundreds of thousands of years, whoever's numbers you use, babies were born in caves and rice paddies. And while that is true, they also leave out that 1 in 4 of those babies didn't survive the birthing process, and about half of them killed mom in the birthing process. So there is a potential for this to go bad. One of the common ways it does go bad is a ruptured uterine artery, which causes massive internal hemorrhage. And if you ask any trauma surgeon, I'm cribbing this from Dr. Mike Smirka, Mike Patterson, Dr. Mike's trauma lecture he did a while back for us, that locating and occluding a ruptured uterine artery is extremely challenging, even for a well-trained OB or abdominal surgeon in a surgical suite. In your living room or in the back of an ambulance, that's going to be really bad news really quick. So if home birth is your choice, if that's what you want to do as a responsible medical professional, we have hospitals for a reason. When at all possible, have your baby in a hospital. That's just the safest option for all concerned.
Yeah, so this is going to be one of those stay and play, load and go. If you get information in your dispatch that, hey, you know what, they're having contractions that are 1 minute in duration and they are 1 minute apart, you're having that baby there.
Yep.
You're not going to try to transport them no matter how close that hospital is.
Yep. Let me jump in there. Test question. You will see test questions involving this. Less than 2 minutes, you're staying. More than 5 minutes apart, and we're going to get to how we measure contractions. More than 5 minutes apart, you got a really good shot of getting to a hospital in our coverage area. Your 15, 20 or minute non-emergent transport or less time frame. And it's that between 2 minutes apart and 5 minutes apart kind of gray area. You're going to use some clinical judgment. You're going to use your history, what are our P's and G's here to make that transport decision to hopefully avoid delivering a baby in the back of your ambulance.
If you do have to stay and play, bring all your stuff to the bedside. If you end up forgetting something, you said, oh, you know what, this is going to be a cake delivery, or, I'm just going to go in and assess them, and then I'm sure we'll be able to walk to the stretcher, to the ambulance. Send a firefighter, a cop, somebody out to go get your OB kit if you didn't bring it in. Bring your suction, bring your first in bag, just everything to the patient's bedside for these OB kind of situations, because it can go sideways quick.
I have a question for you. So if you're on one of those calls and you get called to a patient's house and the mother is in active labor and you do have to deliver there, if she wanted a home birth and never wanted to go to the hospital but is having excessive bleeding, and she needs to go, can she still refuse transport?
She can refuse all the way up to the point that she's unconscious.
Implied consent.
Yeah.
Yep. Once she goes out, you're coming with me. Sorry, babe. And you know what? You can give them as much information as you understand as a provider, and say, hey, these are the risks, up to including death of you and your newborn baby. Are you willing to accept those risks? Okay, sign here, please.
She can refuse even for the baby.
Mm-hmm.
Yep, that's her child.
You can't do the implied consent for the baby.
That's her child. She gets to make all medical decisions for that
So
child.
that child's 18.
And if the father's,
Yeah, and if they're disagreeing, then that's a sticky situation. Again, bump it up the line. Med control. Hey man, I'm on scene. I got this situation that's going on. Maybe you can talk to them and convince them a little bit better than I can.
And your supervision should also be en route at that point as well.
if the father's there and the mother actually goes unconscious, the father can say, no, you're not taking the child.
There you go.
But you can take,
You can take mom at that point.
Yeah, good point, Tim. Yeah.
Unless they produce something that says, hey, I am the power of attorney for this individual, then I am going under an implied consent for treating that mother. Let's see. Normal anatomy, physiology. There you go. Fertilization happens in the fallopian tube. Egg goes down to the uterus, implants, that's where it gets its nutrition.
When we're the ones delivering the baby, are we staying on scene and delivering the placenta too?
No.
Or are you trying to take them to the hospital?
No.
Well,
It depends on the individual.
Yeah.
But you know what?
maybe not often.
I'm saying, you know what? If I can get you into a stair chair or onto the stretcher and then get you, I don't have any reason to wait for that placenta to come. Because the thing is, if you had any kind of issue with that placenta coming off of the uterine wall, what good is it if you have massive hemorrhage to be on scene?
none at all.
It's a bad news bear situation.
Right.
And you want to be at that surgical suite. You want to be at the hospital where there's lots of hands, they have more resources, and they have stuff to deal with that, you know? They have a specialty unit just for this.
Gotcha.
We are jack of all trades, master of none. We know enough to be dangerous. What I can say though is with that, we are masters of emergency and resuscitation. So that's one thing that we're really good at, is identifying problems and getting them to where they need to be. I don't want to be on scene with an obstetrical emergency. I just don't have all the things to do for that. I know where they need to be and possibly what they need to do for that, but I can't provide that.
Right.
More A&P stuff that everybody probably already knows.
And I would actually, unless you were going to cover fluids,
Go ahead.
always like to add this. The reason I go into my little spiel when we're playing with the ambulance, that if you only got the one sheet on the stretcher, there's none on the back and none in the crew bench, and maybe one dirty one that was rolled up to wedge in so boards don't rattle. And your thought process as the EMT is, oh yeah, we'll just grab sheets when we get to the hospital. That will underwrite the fact that your first call that day will be woman in labor. Now, when you have a baby in your belly, as we look at anatomy here, urinary bladder, colon and rectum. When this baby comes out of the vagina, it's also going to push all this material, anything that's in the bladder and anything that's in the colon and rectum, out with it. That's why often in a labor and delivery suite, women in labor are offered an enema prior to delivering. That's why having an ample supply of sheets and blankets are essential in your EMT check off of your truck, making sure your truck is ready for anything you and your partner might encounter.
It may be a surprise to the pregnant mother who is delivering that she will most likely expel all these fluids.
And added to the baby and these fluids, you're probably also going to have about a half a liter of blood.
Yep, 500 mils. It's the typical amount of blood that is expelled during pregnancy, or during delivery, I'm sorry. If it is greater than 500, and estimating blood loss is difficult, especially when it's mixed in with all the other stuff. So if you see a lot, then that's a problem. If it's some, okay, cool, we can deal with this. Okay, this is what I was talking about. Perineum skin between the vagina and the anus, which will often get lacerated just from the stretching of passing the baby through a vaginal canal.
How do you, everything said and done, do you try to put a dressing on it, or you just leave it, or?
Treat it like any soft tissue injury.
All right. I'm going to go ahead and put, number one, a gloved hand there, then grab a sanitary pad or, ABD pad, something like that, putting external pressure right here. When I'm helping to deliver the baby, let's see, I will have a gloved hand right here, putting pressure inwards so that it doesn't have an explosive delivery. That can help guide that child into your hand, and then once the head is through, then you got to worry about shoulders. And shoulders are going to be easier because most of it will be one shoulder then the other that deliver. So I'm going to have my hand right here putting pressure so that we don't have that explosive delivery, which is often what causes that laceration. Sometimes it just happens because of the size of the child and the size of the mother. So there's nothing you can do about that one. But yeah, sterile, sanitary dressing, external pressure.
And for those of you that did not get a chance to review chapter 34 in advance of today's lecture, explosive delivery is a thing.
Yeah, they'll just pop right out sometimes.
There's a paragraph or two on it in there, I promise.
Let's see. Okay, yeah, so this is something that some people might not be aware of, is that milk does not come around until the baby's actually delivered. Breasts do enlarge during pregnancy and it gets ready for all that situation, but yeah, it doesn't actually produce until the baby comes out. Colostrum is the kind of like milky-ish, not like breast milk, but a little cloudy, sometimes clear liquid that is your first production of any kind from the mammary glands. More A&P that we have a pretty good idea of. So where the placenta attaches to the uterus is where you're going to get your blood supply, all your nutrition, your oxygen, everything. So the umbilical cord is your fetus's lifeline to the mother. We talk about the blood-brain barrier. There's also going to be a blood-placental barrier. Certain medications will pass through that, depending on their size and permeability of the membrane. That's why they tell folks while they're pregnant not to take certain medications. They could be harmful to the unborn baby, the fetus. There you are. So you've got umbilical veins, umbilical arteries. Funny enough, the umbilical vein is actually the larger of the blood vessels that are in there. It looks like Dave is probably going to do a little diagram for us. Go ahead. So there is such a thing as umbilical catheterization, where they will stick in like IVs into there. It is a specialized IV catheter, and that's how, like if you're in the NICU, they'll often do that for delivery of medications, parental nutrition. So the thing is, you're looking for the blue one. It's big and floppy. Hopefully you never have to deal with it.
Artery vein.
Yep.
Yep, smiley face. You're aiming for the mouth.
Yep.
If God forbid you ever have to resuscitate a newborn, how you gonna get a line on a newborn?
I'm gonna throw an IO in.
I'm gonna slide a 20 in there and put a little twist tie off of something or a rubber band off of the IV tourniquets and cannulate the vein there. That would be my go-to. Mike knows more about this stuff than I do. If he drill's probably the thing to do.
Hey man, like, I'm not well practiced at this.
Nor am I.
I do IOs like it's, like it's my job. It is. So I'm gonna put a little IO in that new baby, unfortunately. But if we've gotten to that point, it's a bigger issue than just having a needle in their bone. So you got the amniotic sacs. Sometimes they will be delivered in cull, which is they come out with the sac intact. That's an interesting one because then you're gonna actually have to puncture it. All the fluids go everywhere. It's a big mess, but then you have this really interesting story to tell. It's not super prevalent. Doesn't happen all the time, but it is a possibility. Typically, you have the rupture membranes, ROM, or premature rupture membranes, PROM. That's where you worry about maternal infection, was the premature rupture. They need to be in the hospital. They need to be on IV antibiotics until the baby's actually delivered. So your premature rupture would be your amniotic sac has ruptured, but you don't have contractions. That's going to be a lot of fluid, not just like, hey, you know what, I had a little trickle. Typically you'll know if you've ruptured membranes unless you're in the shower in a body of water or something like that. Some may think that they have urinated on themselves. If it's followed with contractions, it's not pee. Okay, yeah, so there are typical changes that happen in pregnancy. Your tidal volume becomes reduced as you go further along in pregnancy because that baby is starting to push up on your ribcage and your diaphragm, so you don't have a chance to expand as much as usual. Your circulatory volume increases up to 50%. Musculoskeletal changes, as in your pelvis is going to widen when you get closer towards delivery. That pubis symphysis is going to either separate or it's going to thin. And then, of course, you've got the growing fetus. You've got thinning of the cervix when you get closer to delivery. You've got a mucus plug that's going to pop. That all sorts of fun stuff. Oh, of course, you get increased hormone levels so that you can better take care of this growing fetus. Trauma in pregnancy is almost always going to be a serious problem. As in, even if it was just a fender bender, you want to encourage that individual to go get checked out because you know what? We don't have ultrasound in the truck. I can't tell what happened internally. Take them to a L&D center. Both our hospitals here in Cobb have labor delivery, so that's not a hard one to get to. Especially if there is going to be abdominal trauma. If they get hit with the airbag anywhere in this region, if they have seatbelt signs, that's obviously going to be something that's concerning. If they have abdominal tenderness, if they don't feel the baby moving anymore, if there has been some change in their activity down here, things of that nature. So, in addition to having that increased blood volume, that they're going to be more susceptible to bleeding and will decomp pretty quickly. Second trimester is when you get a lot of growth. I was talking about those respiratory changes, as in your decreased minute volume. You don't have as much room to have. So to compensate for that, you breathe a little bit faster so that you can keep the same homeostasis for your respiratory compensation. You get increase in blood volume, your red cells increase, Heart rate's going to go up a little bit because you've got an increased metabolic demand as you're growing this baby. Nausea and vomiting, that's a common complaint. They, for a while, had you take Zofran. Then they find out, oh, Zofran can cause birth defects. Sorry, guys. So there's a class action lawsuit against that one.
To that point, yeah, it was 1 in 100,000. Earlier on, that's why we have these axioms. One of our EMS axioms is all female patients of childbearing years are pregnant until proven otherwise. Ladies, when you show up in clinic, in the emergency department, in urgent care, at the doctor's office, what's the first thing they do? Make you pee in a cup, absolutely, because they want to verify that you're not pregnant. 1 in 100,000, the best numbers show of babies that were given Zofran, or moms that were given Zofran early on in their pregnancy, there were birth defects, and that's just not a risk we want to take. 1 in 100,000 doesn't sound like a lot. But if that's your
one
child, that's a pretty important one out of that 100,000. So.
Hey, could you potentially be pregnant? If you ask that question, a lot of folks will say, no, there's no way. So you've never had sex in your entire life. Well,
It's a miracle.
yeah. So there is a chance you could be pregnant. It is a low index of suspicion if you haven't had intercourse in the past 12 months. But when these people, when you ask them, hey, is there any chance you could be pregnant, they won't think that far into it.
Or
You
if
know?
you haven't had intercourse with the opposite sex.
There's that. You know? So
Parthenogenesis is a thing.
but yeah, so you have to kind of explain to them a little bit the potential for pregnancy. Even if, hey, I'm on birth control and we used protection, and it's like, okay, there is still a chance. Those are not definite.
I was conceived, my mom was on birth control,
Yep.
and my father was wearing protection and freshly
Snipped?
snipped.
Nice.
Yeah, so.
You're a fighter.
Yeah. Yeah, me and my younger brother were born after that.
Wow. Okay. Yeah. So vasectomy is.
They get the money back on the vasectomy?
So this is one of the things that we worry about as far as airway management. Because of that gravid uterus, it pushes everything a little bit up, that stomach included, which can cause reflux. Aspiration is one of the things that you worry about with somebody who is going to be altered mentation. So if you have this chance, go ahead and kick that head of the stretcher up to 35, 45 degrees so it helps unload that weight. If they are supine, then everything's going to be falling kind of upwards towards the head, so phallic. So we want to kind of unload that weight, put them at an angle, let everything drop down towards gravity. Weight gain is normal during pregnancy. We want to talk about healthy weight gain, and they should be going to their OB and tracking that. They'll be able to tell you whether they're on track, if they're gaining too much, if they're underweight. So the connective tissue becomes a little bit more loose during pregnancy in preparation for that baby coming, so that you can actually pass this person through the vaginal canal. Center of gravity. So yeah, you're going to have a little bit more weight in front, so it can cause these stumbles, trips, slips, anything like that. So those, again, you do want to recommend that they go get checked out. It doesn't mean that they have to take a ride in your ambulance, but they should go get evaluated, whether it's with their doctor or at the emergency room. So this goes all the way back to our STIs. So you can become ill during pregnancy. You can become ill during delivery. So those are going to be some issues, especially during delivery, that we need to cover, quote unquote, with antibiotics. That's not going to be something for us to do, but it's something to report. Say, hey, you know what? She had premature rupture of membranes. She's got a fever now, and she looks a little sick. We'll go ahead and we'll tell them all about that. Yeah, if they need oxygen, give oxygen. You know, there's no in the amount of time that we're going to have that patient, we're not going to do much harm. Granted, if you put somebody on high flow And they talk about COPDers. You say, hey, you're going to knock out their hypoxic drive. Not going to happen at the time that we have them. So if they are hypoxic, they need oxygen, give them oxygen. You got to remember always you've got two patients with somebody who is pregnant. You got the mother, and then you've got the baby, and or fetus. You have to treat the mom to then treat the fetus. Because if mom dies, the baby obviously dies. We can go as far as to talk about, hey, you have a cardiac arrest in the mother. Keep working that mom, because then you are helping the baby survive. And sometimes they'll even do a post-mortem C-section on a fetus to deliver a baby. They say, hey, you know what? The mom is too far gone, or they're not getting them back, or anything like that. But there can be a positive outcome when they deliver a child from this individual who has unfortunately had a cardiac arrest.
Crash C-section, that's the thing.
Yep.
Look at it.
Like a justice context.
ఏంటి ఫిజియోథెరపీ పరదలా ఉంది अच्छा सांस लो लंबे लंबे
कौन टच करो बोले तुमको bulging bladder. Bulging bladder. యూజ్ చేయాలా
Had one of those, didn't even know the patient was pregnant with twins. Brought her, she had a cardiac arrest in a gas station parking lot down in Smyrna area. Took her into the hospital and they did an emergency C-section. Unfortunately, all 3 passed. I didn't put her in that situation. I just wasn't able to help her through that situation, unfortunately.
I have 2 questions.
Absolutely.
First one, just because I've seen it on a test, but I don't know if we've gone over it. Mom is big pregnant and you're doing compressions. What do? Do you just go higher up on the chest or do you move the baby?
So that's going to be an interesting one because if you are supine and you have that gravid uterus that's weighing down on you, it's going to be compressing the inferior vena cava. So you want to either manually displace the fetus or you want to put them on one side or the other. Preferentially, you'll move them onto left lateral recumbent, or just basically if you have them and you're having to do CPR, they should be on the backboard. Shove your jump bag underneath the backboard and then continue doing CPR. What was the other word?
My second one is, do you shock them?
Yeah, if they need it. Yeah, so if their heart rhythm is disorganized and it is a shockable rhythm, go ahead. Hit them with that Edison medicine.
What does it do with the baby? Anything?
I don't know specifically, but knowing what I do know about doing like electrical cardioversion, you got a pad here, right? The idea is that it goes between both poles.
So it should fix the baby.
It should, in theory. So, and it goes back to, hey, if mom doesn't survive, baby doesn't survive. If we get to the point where mom survives, but we lose the fetus, that's unfortunate, but hopefully mom can try again. Instead of having 2 deaths, you have 1. So you can get gestational diabetes. They will often do, no, not often, but they will always do a glucose study for a mom. It'll resolve after you deliver your child. They'll treat you the same as any other diabetic. So, gestational hypertension. This can lead to preeclampsia or eclampsia, which are true emergencies.
You will see eclampsia and preeclampsia on tests. Yes, in OB emergencies. So you need to know what they are.
140 for the systolic, 90 for the diastolic. Those are the numbers for hypertension. Preeclampsia would be the ones where you are above that and you have symptoms. Eclampsia is going to be the one where you have seizures as a result or significant symptoms. So.
And if you had to pick one word to describe a seizing pregnant patient, catastrophic. Yeah, that's.
I don't want them.
That portends a bad outcome for both mom and baby.
The treatment for that is going to be magnesium. You're going to have an ALS provider do that, or you're going to get them quickly to the hospital. It's not benzos with this patient. It's one of the times where you have a seizure that won't get fixed with benzos. Preeclampsia, there you go. Can be developed after the 20th week of gestation. You can have these headache, visual changes. So it's these people who constantly, like with hypertension. If you have, Peepaw, who has a blood pressure of 180 over 110, acutely, he may have some of these symptoms: splitting headache, visual disturbance, balance disorders. Let's see, swelling will happen. Eclampsia, there you are, characterized by seizures as well as that hypertension. That's going to be on the higher end of the 140 over 90 situation. Absolutely ALS. Do your ABCs. Put them in the recovery position, maintain an airway. It's just basic seizure care until you get ALS, or if you have to transport them, put them in this position. Keep them away from things that could hurt them, like as in a falling object off of a dresser because they seize and bump into it and then it hits them. Don't stick anything in their mouth. I hope that everybody is clear on that one. It goes for any seizure. the old adage was that, oh my God, they can swallow their tongue. It's not gonna happen. It's attached to their throat. Your airway can become occluded by your tongue. However, we know how to manage that. If it's a trauma situation, you got a jaw thrust. If it's non-trauma, you got a head to chin lift. If they're on their side, usually it'll maintain patency. Other ways we can do that is do a BLS airway. You got an MPA, you got an OPA. There you go. If you need to provide ventilation, and they are on their side because they have gone into an apneic period, I would do a two-person kind of ventilation situation. I have one person holding the mask and one person squeezing the bag. Because you do want to maintain them on their side so that they don't aspirate, but you also want to ventilate them. And that's going to be really hard to do. If they're laying on their side, you're awkward doing the one-hand EC and then trying to squeeze the bag. Hopefully you've got ALS en route and you've got plenty of hands to handle this seizure patient. You're going to want to check blood glucose too, because that could be a cause for seizures that is not related to this. Rule out all your other situations as well. Do they have a history of seizures? Are they on their medications? Did they skip a dose? Whatever. Suction as necessary. So we were talking about that supine hypotensive syndrome. So when you have that gravid uterus flat, your inferior vena cava is going to become occluded, and as we know from distributed shock, if you've got that happening, then you're not getting proper preload back to the heart, which is going to cause you into a cardiovascular collapse. So, lat on the left side is a good one. Oh, okay, here we are, on to ectopic pregnancies. So this is when it is outside the uterus, most often in the fallopian tube. We kind of covered that one. Everyone who is of the childbearing age who could potentially be pregnant with an abdominal complaint is considered pregnant until proven otherwise. If they have complaints of pain, etc., whatever, you're going to consider ectopic until proven otherwise. And you're going to do this through your history of present illness, your physical exam, and your history taking.
Why? Why is it ectopic until proven otherwise? Well, you're both right, but
Because you can die. That's
because
why.
it is a potentially life-threatening emergency.
Yep. So if you have a ruptured ectopic, you're going to be bleeding internally that we cannot visualize. You would have peritoneal signs where it would be, discomfort. You may have like that Cullen's or Murphy sign, and distension, pain, hypotension. But all that stuff is going to be late signs. You're not going to see that right away. So you can bleed a fair amount into your abdomen before it's apparent. I'd say just throwing a number out there, it's not scientific at all. I'd say 1.5 liters probably before you start getting that significant distension where you can see it.
One of the 5 places you can bleed to death, peritoneal cavity. This is one of the causes of it.
Go ahead.
You said 1.5 liters. Would that be the same if they were pregnant? You could still bleed out 1.5 liters before it starts to show, even if there's this.
Oh, so like if you're gravid, you're probably gonna have more.
Okay.
Because if you have that, gravid uterus, it's probably gonna be able to mask some of that bleeding. We're gonna get on to one that, 2 of them in fact. One is a placenta that has separated from the uterus wall, and then the other one is where the placenta has affixed itself over the cervix. So we'll talk about that in just a second.
Does anybody know what those are called? Those 2 conditions? Abruptio placenta, and the other one?
Is that the spontaneous abortion?
No. Previa, yes, placenta previa. You will see those terms on test questions. You do need to know them.
So placenta previa is where it is over top the cervix and the uterine exit. placenta abruptio is where it separates from the uterine wall. So both of them will have intra-abdominal bleeding and uterine bleeding that is masked, is hidden. So your patient could be hiding 2.5 liters in their abdomen before you even realize it. You will see external signs, as in they are hypotensive, they have altered mental status, they look big, sick, but you won't see much external hemorrhage.
You will see more in abruptio.
This is if you deliver through
Yeah,
that
okay.
placenta in that
Fair, yeah.
area where it has affixed to the uterus at that cervix.
What are you looking at as far as blood pressure and pulse and stuff?
So for pregnant individuals, I'm thinking that they're probably going to be about 25% of their normal. They should be generally within the norms for an adult of their age, you know, without pre-existing
Like,
conditions.
if this is happening, is this
But Chris,
the blood pressure are turned up?
No,
Chris,
no, no.
what's happening? What type of
Compensation?
what type of shock are we talking about?
Hypo.
Yeah, hypovolemic shock. This is just bleeding where we can't see it. Hypovolemic shock.
So you're going to be tachycardic, you're going to be hypotensive, you're probably going to be tachypnic as a compensation for it. You know, you're bleeding internally, so you don't have oxygen running around because those red cells are bleeding in. So your body's going to go, oh, I'm hypoxic. Let me breathe quicker so I get more oxygen. So that's probably what you'll end up seeing. So this is your abruptio placenta where it has separated from the uterine wall. You're going to have bleeding, and it doesn't have to be up top where you're attached. It could be over on the side here, and you're bleeding, and then it'll come down this way. This is the one where you may see external hemorrhage. This one right here, it mostly will be hidden because you're going to be bleeding this way. You may see some, if you were starting to deliver through this, you're going to have a patient who is profoundly hypotensive. They're going to be shocky AF. That's a person, lights and sirens to the OB. Give pre-arrival, say, hey, we need a surgical suite for this individual. You might want to get MTP, massive transfusion protocol. Abortion is not a dirty word. It is a medical term. There is a spontaneous abortion or miscarriage.
You will need to know for testing spontaneous abortion after 20 weeks, they're going to call that a miscarriage, and at term, they're going to call that stillbirth. So those are terms you're going to need to know.
Before 20 weeks.
Yeah, prior to 20 weeks, a miscarriage would
is 20
technically,
before delivery, and then after, and then during delivery.
at term, yeah, it would be stillbirth.
Okay.
Yeah.
There is still elective abortions, you know, for whatever that person needs to have that happen. You know, that's not a dirty thing either. You need to respect the individual and their choices. It's kind of like Jehovah's Witness. They don't want blood products. So that's their choice. You don't get to pass judgment on somebody for their healthcare choices. You may think it in your head, but just don't let them know about it. I mean, I think it's wild that you wouldn't want blood products if you're hemorrhaging, but hey, you know what? That's what they believe. It's a statistic that's true, is that pregnant women are at increased risk for domestic violence. When they do have these incidences, it could be more significant because they are carrying somebody else, you know, they're carrying a fetus. It goes along with that whole, they're compensating for growing this individual inside them. There is increased risk for the spontaneous abortion or miscarriage, being born premature, and low birth weight. This could lead to maternal death as well. So what we were talking about earlier about, hey, you know what, women have been doing this for thousands of years in a field, you know, all by themselves. Yes, but maternal death was way high, as well as fetal death. So we're trying to reduce those kinds of situations always. And that is actually a measure in developed countries, is what is your fetal maternal death rate. We're always trying to reduce that, and unfortunately Georgia is way high up on that list in America. We're somewhere in the high 40s. So.
That correlates with the number one cause of death for persons under 18 in the state of Georgia. Non-accidental trauma.
Scene survey is going to be a big one on this one. You're looking for context clues, signs of like drug use, broken furniture, beer cans laying around, places in poor repair or dirty. These are the things that you want to include on your PCR. With your scene size up, and you say, "Hey, we arrived. 702 arrived to a trailer that was in disrepair. There was trash indoors to include empty beer cans, potato chip bags, rat feces. Mother was found, lying supine next to a roach carcass, something like that." So make sure that stuff is included so that you can paint a good picture to the people that are receiving that individual, and then maybe mention that when you're dropping them off. Say, "Hey man, I found them in this kind of like funky trailer. I don't know what's going on. Maybe you guys can investigate a little bit or get social work involved." That's one of the best things about taking them to a hospital is that you get social work involved, because we don't have that option on the truck. And that's the best place for them to get that referral.
Do you report drug use in a pregnant woman at DFACS?
I don't report it to anybody but the receiving clinician, and that satisfies your requirement.
Right.
Well, that's what I mean. I didn't know if that was
Yeah, as-
a horrible thing.
As Dr. Mike said in the trauma lecture, one of the beautiful things about being in EMS,
Yeah.
anything you tell the doctor becomes the doctor's problem.
Yep, that's the best thing. Kick it up to somebody who's higher than you.
Well, see, that's pretty much what I said. Do you report it?
Yes.
Yes.
You, as a mandated reporter, you are required to do that by law. So when you tell the nurse or the doc, that satisfies your requirement. It is their responsibility then to get DFACS, social work, all those channels involved.
So in that situation, would you be able to bring like the baby home, or how would they handle that?
So DFACS would do, or social work would do their interview, and if they needed to, they would get DFACS involved. DFACS would open a case. They would do a home visit. They would kind of see what's going on, why is it happening, and then decide whether it's a safe environment for the mother or the baby together, whatever. In cases where they deem that it is not a safe environment, they will take custody of the child. Unfortunately, substance abuse doesn't end when you get pregnant. As you imagine, it can cause low birth weight, birth defects, early birth of the child. There are some folks who are in treatment while they are pregnant. That has been approved by their addiction specialist, their PCP, whoever, their OB. And you might see some folks who are on like methadone or something. But they're receiving, if they are on that, they're most likely receiving treatment. You just ask them about it a little bit. Say, "Hey, are you following up? Are you on a plan? Are you in a program?" And there's not much that we're going to do for that. If you do have somebody who has like an opioid overdose, which is something that we can easily treat, a little bit of Narcan, support the ABCs. On that tip, if you have an opioid overdose, the most important thing is not the Narcan. It's going to be the airway and the breathing, because that can immediately solve the problem. You're going to support their ABCs, and then if they need it, you can give them a lower dose of Narcan, because our initial issue is going to be the problem that they are not ventilating and they're not maintaining an airway. So we need to take care of that before they go into circulatory collapse. Then we can worry about, what has caused this respiratory depression. Because it doesn't always have to be an opioid overdose. They can have respiratory depression for any number of reasons. But just wanted to hit on that real quick.
So I have a question.
Go ahead.
Whenever you deliver a baby that is suffering from withdrawals, whether it's from a street drug or methadone, are you giving the baby Narcan?
I'm going to let that get taken care of by somebody who is much more educated than I am. They get paid more than I do, and they have better liability insurance. Because one of the things that you can do with individuals, whether they are pregnant, whether it's a newborn, whether it's Joe Blow off the street, you can send them into acute
Withdrawal.
Thank you.
Yeah, well, and the reason, Mike's answer is correct, the reason I was shaking my head is because what does Narcan do? Blocks, so it's taking them the other direction. If you had a baby that was delivered and is
Done it every day.
opioid dependent or highly opioid tolerant, the last thing you'd want to do is give that baby Narcan, because that would hasten the withdrawal.
They can even go into seizures with that because of the
Exactly.
acute withdrawal.
And while we're on substance abuse, there is actually a lot of data. When my generation, we got a lot of bad medical information about HIV/AIDS. We also got a lot of bad information about crack cocaine.
This is your brain on
Yeah.
drugs.
Anybody ever heard of the term crack baby? It's actually fetal alcohol syndrome. There's all kind of data right now that is leaning towards the cocaine was not the problem, the way it's metabolized out, that all those ill effects on those infants was actually due to alcohol. It's actually fetal alcohol syndrome, and there really was there's some mythology to the crack baby syndrome.
So when we do have that infant who is opioid dependent, we're just going to support ABCs till we get into the receiving. Simple maneuvers, if you have to, you throw an OPA in there, NPA, ventilate them, give them oxygen. Simple BLS stuff, but it's highly effective. On that, Dave has had up here the APGAR, and so it's going to be very similarly if you have a baby that is limp, blue, poor tone, etc. These could be things that are a result of that opioid that is in their system. It's the same exact stuff you're going to do for resuscitation of a neonate. Warm, dry, suction, and ventilate. Look for your context clues on scene. Try to piece together, the idea of kind of like what situation this is. Scene safety, big thing. If you don't feel comfortable, just back out. You can't help anybody if you become a victim. So yeah, trauma and pregnancy, you got 2 patients. If the mom dies, the fetus dies. So let's try and take care of mom. And hopefully the fetus gets good perfusion if we're treating the mom effectively. There you are, we got the loose connective tissue again, risks of falling. You've got that gravid uterus that's hanging forward. There you go, so 20% increase in heart rate can be expected during pregnancy. They can have profound blood loss before you notice anything. Talking about bleeding in intrauterine. There you go. Your fetus is going to show the first signs of distress. So, say for instance, I have a mom. We put her on totometry, which is it detects fetal heart tones and heart rate through a strip. Then I, have mom donate blood. We bloodlet her for a unit. That baby is going to get tachycardic and then eventually bradycardic prior to mom showing signs of quote-unquote blood loss. So trauma is going to be your abruptio placenta that we need to be aware of. Again, if you have any kind of traumatic injury, just refer them to the hospital. Come take a ride with me, man. Or, hey, you know what? You really need to go get checked out. So, seatbelt size is going to be a little bit lower. Typically, for a pregnant woman, it needs to sit low and across the hips. A lot of them will take that shoulder belt and put it behind them, so it could cause improper restraint. Then you'll have extra pressure on those hips on the pelvis. You might get smacked with the airbag real hard if you don't have that shoulder belt across you. Looking for those seatbelt signs, external hemorrhage, and mom who's compensating or decomp. Cardiac arrest, take care of the mom. Pre-arrival notification so that they can hopefully have OB come down from the unit and possibly do a postmortem C-section. Be aware of that vomiting aspiration if they have a decreased LOC. Have your suction set up and turned on if you have anybody with altered mentation. Because the worst thing that can happen is you need that and you go to hit the button and it is not working properly. So if you got somebody, we've got plenty of supplies. If you don't use it, that's okay. If you don't know the age of the gestation of the fetus, there is a way to estimate, and it's depending on centimeters above the umbilicus or navel. Umbilicus, yeah. Umbilicus, whatever you want to call it.
With your trachea and your aluminum.
Yeah, so
And
esophagus
your vitamins.
was my favorite one. Was my AMP instructor. He said esophagus. Yeah,
That would be esophagus, gang.
if I'm remembering correctly, and don't take my word on it, but if the fundus is right at the umbilicus, it's 20 weeks, and then for every centimeter above that, it's 1 week. So it might be 20, it might be 24. I can't remember right now. Anyways, we're probably not going to be estimating. There's probably going to be somebody on scene who knows if they are unresponsive. So if they're responsive, just ask them. Hey, in their pocketbook, in their purse, in their car, they may have discharge paperwork from their last office visit, which would have information about their history, their date of birth, the gestation of the baby, so snatch that stuff up and find it.
We call this wallet biopsy. Grab whatever material you can that can help.
BLS ABCs for your trauma patient. Cultural sensitivity. So this can come into play in many different ways. Right now we're in the middle of Ramadan. I actually treated somebody who had gotten lightheaded, syncope, because they were fasting all day. And we had gotten all the way to sundown. And they're like, dude, it's just about time for me to eat. Say, do I have to go to the hospital? No, you don't have to. Like, I'm gonna respect whatever you would like to do. If you want to stay at home and eat, by all means, go for it. You have to take into account their belief system. By all means, do it. No judgment. We're here to help them in any way we can, and it's not our job to pass judgment on this individual for what they are going through. This male healthcare provider, female patient kind of situation, there are some cultures who are like that. If it's not a life-threatening situation, just roll with it. Okay, I can talk to you about certain things, and there are certain things that you'll notice that they get uncomfortable about that you just don't go down that alley all that much. You say, okay, we can go into a different method of questioning interview. If you do have that option of having somebody of the same gender, go ahead and do that one. I'm a teen mom. This can be either a comfortable or uncomfortable situation. Privacy is going to be important. They may want to keep this private from anybody around. They may be happy about their pregnancy. And this goes with any kind of pregnancy. You know what? They may be elated that they're pregnant. They may be upset, because of, you know what? I don't have the time for it. I don't have the money. I'm already in debt, just whatever. So don't always assume that a pregnancy is a positive thing. Don't assume that it's a negative thing. It's just a thing that we're then going to treat the individual. So putting them into your office in the back of the truck, having somebody with you so that you have two caregivers who can corroborate stories should anything go sideways. And yeah, just the same questions of, hey, when was your last menstrual period? Is there any chance you can be pregnant? Okay, you've never had sex. Okay, let's talk about this, yada, yada. So we've gone over that stuff. So sometimes you don't know. I didn't know I was pregnant. It may be unexpected, it may be a positive, it may be a negative unexpected. Those ones when it is unexpected, you can expect more complications because they haven't had appropriate prenatal care. This could be low birth weight, it could be a child with an APGAR like 3. You could have congenital deformations, whatever. Gloves, eye, face protection. get it on, man. You don't want somebody's nasty genital juices on you.
Gowns, booties for the shoes, whatever you got.
All of it.
Yeah.
At its very base root, it is body fluid. If it is wet, not yours, don't touch it. Don't let it get on you. So that would be something that I would advise for all these OB calls. So calling for additional resources, that's one where if you know that you're going to deliver a kid, get a second ambulance en route. So here at Metro, it is protocol and policy to send a second unit. That doesn't mean that our human dispatchers could forget to do that. It happens, we are humans, we make mistakes. Say, hey, just clarifying that you have a second unit en route to this OB call.
Yeah. After you arrive on scene, you do your assessment. No crowning, time of contraction or two. Yeah, we've determined we're having the baby here.
Or you can say, you know what? We're not. We're going to take him to the hospital, cancel the second unit.
There you go. In that scenario, but we're going to have the baby here. 212 radio, delivery imminent. Just confirming we got a second unit en route.
Sometimes they'll send them non-emergent. You can tell them to upgrade to emergent. Or if it is something that is, one of those things where it's like, yeah, I'm not quite sure, we're on the fence. Hey, you know what? Downgrade them to non-emergent. It's less risky for that crew, for the public in general.
If mom is having twins, is one extra ambulance still enough?
How many patients do you have?
You gotta have
Ten
three
or
trucks.
three?
Yep. So how many trucks are you going to have?
Three.
Yeah.
There you go.
When you
And-
deliver them to the hospital, are you really separating everybody?
Absolutely.
Yeah.
That I've done that a handful of times. It's never been a problem with mom.
Mom was upset with me one time because
Okay.
I separated, but I was like, hey, this is the safest way to get
Yeah.
you and your child to the hospital.
Yeah.
Because say there's an emergency with one or the other.
Mm-hmm.
I don't want to have one medic in the back trying to handle two potentially unstable patients.
Right. One critical patient per ambulance.
Yep.
That's the way you want, and you have potential for both going south. I've never had a problem with mom. Usually mom's so tired at that point. Yeah, whatever. Just take us to the hospital. Dads have gotten their backs up a little bit about that, and the way I politely and quickly explain that is we don't want two critical patients in the back of the same ambulance at the same time, sir or ma'am. Everybody is fine right now. But like Mike said, if one of the two goes south, then there's no one to take care of the other patient who's going to need a level of care.
So
And-
you're on your way to the hospital, the mom surprisingly goes into labor, you pull over, then do you just wait on the side of the road for the second ambulance to show up? So that, and then,
At that point, it's a judgment call.
Yeah.
Where you're located, how the patients are doing, if it is an imminent delivery.
To clarify, we're en route. I got the timing wrong, and the call was for a woman in labor. We've now pulled over to deliver the
Right, right.
baby. Yeah.
I'm saying it's crowning, you deliver the baby, like it's crowning, it's done, you deliver the baby, unexpectedly.
Well, and
Like
we've had 9 months worth of warning. When we get to that portion of it, we're going to talk about 1 minute, 5 minute APGARs. If I'm doing a resuscitation, if it was a complicated delivery, that one or more patients is crashing and I am a good distance from the hospital, yeah, I'm going to have the cavalry come to my scene. If I'm at Church and Church Street Extension, that's really a judgment call per scene, per scene, per patient acuity.
It's really going to depend on kind of like where you're at in the county situation, like where your resources are. Hey, you know what? I've got an ALS fire station right on the corner. We're going to pull in there and wait for a second ambulance.
Another good call. Because there's an
Or-
awful lot of help in there. And another cardiac monitor maybe too if it's got an ALS engine and a rescue. Yeah. Cut.
then I have one other.
Actually, I think Kylie had a question.
So just speaking from my experience, it took me like 5 ever to have my freaking kid. I was pushing for like 2.5 hours.
Ever.
So
It's a little longer than forever.
It's a good one. I'm going to steal that.
how long do you stay on scene?
I can tell you that I was with a brand new medic. He had helped deliver as an AMT, but this is his first time being the
Catchy.
big guy on scene. Yeah. So our ambulance was double medicked. You've got him and his EMT. So you got 3 medics on scene, and we just kind of sat back. We're like, whatever you need, man, I'll help you out. Funny thing is that this guy brought in only the OB kit. That's it. I was like, hey, you know what? I'm going to go and get all the rest of your stuff. You keep going with this.
For the record, there's very little, other than a bulb syringe, there's very little airway management stuff in your OB kit.
Yeah, I know. So, so my partner kind of hung out, made sure everything went well, and contractions were 3-4 minutes apart, and I was like, Cobb Hospital is about like 20 minutes from here. But hey, it's this guy's scene. I'm not going to butt in. We were on scene for like an hour and 20 minutes because he wanted to wait for the placenta to deliver. The baby came out fine like 30 minutes after we were sitting there. Wanted to deliver the placenta. We took the mom, he took the baby. It's just entirely too long.
I mean, like, my question is, like, I was actively pushing for 2.5 hours.
Yeah.
And I was just having a real hard time, so I ended up having to have an episiotomy. How long would you, how long would you decide?
If you are actively pushing with contractions 1 minute apart, I'm probably going to sit there for 15, 20 minutes, go, this baby ain't coming. Let's go, baby.
Yeah. Or when in doubt,
Call
medical control. Call your,
the doc.
yeah, while we're in that mode of calling people, when you call in a radio report, and we're going to get to P's and G's here in just a second, we don't say patients' names over the radio. One of the most valuable questions you can ask up front, have you had prenatal care?
Who's your OB?
Exactly. Because once you've gathered all this information through your OPQRST and your sample history and the patient, we can't say the patient's name, but if we're going to Northside Atlanta, where the patient's OB is at, I'll bet you that
They're expecting that patient
Yeah.
in the next couple days.
yeah, and added to which Dr. Obstetrician Jones only has maybe one 31-year-old patient, weeks, 39 weeks, whatever. Once you feed them all that information, they're in a much better spot. They can have every piece of your chart, all that data up and ready when you arrive.
Yeah, so it's a judgment call. I said I'm not sitting on scene for more than 20 minutes. Because at that point, I've got more stuff to do. Their call's holding. You'd be best served in a hospital, instead of us just hanging out here. I'm probably not going to be giving you any pain medicine and say this is natural. Sorry.
Why don't we go to where there is pain medicine?
Yeah.
But
they are
in
specialists in this.
Yeah, in that scenario, I would probably make the call. This is where we're at. Do you want us to go ahead and transport to your L&D?
So primary is XABCs, your general impression, sick, not sick, load and go, stay in play. When it says perform a rapid exam, external. We are not doing a digital vaginal exam to see how dilated they are or how effaced they are. We're just looking to see if there's a head coming at us or if there's feet coming at us. That sucks. Still manageable.
Well, feet.
Better than a butt coming at you.
Well, feet's better than foot.
Yeah. So, or arm.
Yeah.
So you do need to evaluate those things. So you do, hey, I'm going to have to do an external exam. I just got to quick peek, see what's going on down there, and then we'll decide what we're going to do. Hey, are we going to go or are we going to stay? ABCs, XABCs.
What's the X?
Yep.
Sanguinating hemorrhage, yeah.
So you can bleed in, right? It doesn't have to be external hemorrhage. You can be bleeding in with these patients. MBC assault or any kind of medical condition can cause a life threat, as we've discussed. Circulation, there's going to be some expected blood loss during delivery. If there's significant hemorrhage, let's get them to the place where they need to be. There you go. Delivery is imminent. We're going to birth that baby there. Hopefully it's uncomplicated and simple. If it then becomes complicated, we're going to move you as rapidly as we can to the place where they can fix that. Don't try to birth a baby in a moving ambulance.
Bad idea.
Yeah. Don't try to do many interventions in a moving truck. The only thing that I would really do is like immediate life things or starting an IV, maybe. You know, like, hey, you know what? This guy's crashing. We need to get them to where they need to go. I'm going to bag them. Or, you know what? They are severe respiratory distress. I'm switching from the non-rebreather to the CPAP. You know, those kinds of things are okay in a moving truck. But like trying to intubate, trying to deliver a baby, what else are things that you wouldn't want to do?
Thoracotomy. the point being, you're going to do procedures in the rain on the pavement underneath a rolled over pickup truck. When at all possible, do it comfortably.
Bring them into your office.
Yeah, don't make things harder than it has to be.
Those are your indications for rapid transport. These are your history-taking pearls.
Yep.
Your sample's the same as we've been doing, but specifically, let's talk about PCGs, para and gravid.
Okay, so in that scenario, 4 kids, we're pregnant now.
4 live births.
4
because
live births.
Somebody could have died in the interim.
Yeah, 4 live births. Baby is born, takes a breath. We're pregnant now, so we are G6, P4. That baby shows up, and it's triplets.
So you go from 5 to 8.
We are G6, P5. All the twins, the triplets, the quadruplets, the octomom count as 1 live birth.
So what if one dies and the other one lives? Is that still count as one?
Yep.
As long as one of them takes a breath?
No, as long as that baby, you know.
Yeah. And all the twin, triplet, quadruplets, sextuplet, however many come after that, if any of those, yeah, it's not how many living children, it's how many live births you've had.
Not to keep Mike here too long. Go back to first time she's got twins. And she's pregnant with twins.
Okay.
No other kids, nothing, never had any before. This is her first pregnancy period.
Yeah, okay, first pregnancy period.
Right.
She's
got twins.
G1, P0.
Because she has twins, but
Yeah.
then it still counts as P1, G1.
Exactly.
Yeah, okay,
Yeah.
gotcha. And
If
then to Kylie's question, twins, one dies, one doesn't, it's still P1, G1?
See, that was my question.
Yeah, because the
we're talking about the birth event.
yeah, how many live births, not how many currently living children you've got.
I mean, I think our questions were like, say one's stillborn and the other one's living, that's still.
That is a live
P1,
birth.
G1.
Okay,
Yeah.
so as long as one of the kids take a breath, it's still a live birth.
Correct.
Okay.
I'll finish this one real quick.
Yeah.
So, if the water has broken prior to your arrival, you ask, like, what was the color of the fluid? A lot of times it'll be clear, might be a little bit bloodstained. If there is some weird color to it, green, black, brown, whatever, that's probably meconium staining, which means that the child has pooped in caul in the uterine sac. That's a sign of fetal distress. So that's something to report to the ER, OB, whatever. And if they then take that into their lungs, that's bad news bears. They are going to spend some time in the NICU most likely.
And as an adult, will likely have asthma, respiratory issues, that kind of thing.
So we're moving into the different stages of the labor. There is like rupture of membranes, dilation of the cervix, effacement of the
Cervix.
yes. You actually have like the delivery of the fetus and then delivery of the placenta. One ends when the next one begins. Contractions that are going for a whole minute, they expect the baby to come pretty soon. It's painful from what I understand. Never had a personal experience.
Best way I can describe that, Holly and I were delivering, not a delivery, woman in active labor call, had enough time, we were on the way to, getting set up to head out to the hospital, and timing, contraction was coming on. She asked me, have you ever felt a contraction? And I said, no, boss, I didn't think I was capable of feeling a contraction. And she said, that's not what I mean. Asked the patient, do you mind? And the patient said, sure, that's fine. Holly grabs my hand, puts it on the patient's abdomen, and it feels like pregnant abdomen. And then when the next contraction started, it didn't feel like abdomen, it felt like literally hard as a rock. That, and I can only imagine how painful that must feel from the inside.
So like we're saying, if you have had multiple children, the baby's probably going to come a lot quicker. If it's your first kid, then you can expect a prolonged labor. Not always, though. There are these Braxton Hicks contractions. Those are your uterus preparing for the delivery of the baby. So a lot of people will call that false labor, or they'll get concerned because they're 32 weeks or something. They feel these contractions. They think that labor is coming on. They'll call you, say, "Hey, I'm having early labor." Or just run up to the hospital anyways. It's not for us to decide whether they are active labor or not. Basically, have you ruptured your membranes? Are you crowning? No. Okay, we'll take you on up there. Because if we're answering those two questions with yes, then we're going to prepare for precipitous delivery. There's a difference between false labor, Braxton Hicks, and true labor. Premature rupture of membranes.
Let me jump in real quick. Actual test question. In what stage of pregnancy is the fetus delivered? 1, 2, 3, or 4? Exactly, 2. There is sequential numbers, eliminate A and D, it's either B or C.
There are different stages of these different sections of labor. When we're actually lightening and moving down the birth canal, we call it lightening. There are different stations. This is something that your OB nurses and docs will know more about. We don't really need to know it because we're not going to be looking inside to see where they're at. So the second stage is when the baby is actually coming through the birth canal or vagina. Ends when the kid is actually out. This is where you're going to have your strongest and longest contractions. This is what we're talking about with the perineum bulge and possible laceration thereof. Put your hand against that perineum to prevent that explosive delivery and to ease the delivery of the child's head or presenting part.
So it's not crowning per se that starts the second one, it's just, not that we would be able to see it, but.
So it's when the kid is moving down the birth canal, and we will observe crowning as that part of that stage.
Okay.
Baby's out, and then you are starting for the placenta to come. It separates from the uterine wall. You'll have some bleeding at that point. It's a highly vascular organ. Bag it and take it with you to the hospital because they will want to inspect it to make sure that it is intact. There are times when there will be pieces of it that adhere to the uterine wall, and what they'll have to do at that point is a surgical procedure to dilate the cervix. They go in and kind of scrape all the remnants out. That doesn't happen immediately, but it'll happen within the next day. They'll be admitted to the hospital.
And why is that important? Exactly. Yes, there is portions of tissue that are no longer being fed with blood and oxygen inside the patient's abdomen. They will become necrotic. That will create infection. That patient will become septic.
Yeah, we refer to those as retained products of conception. It can take 30 minutes. It can take longer. Sometimes they won't deliver. their placenta in your presence. That is a retained placenta. That definitely needs to be admitted to the hospital so that they can take care of that in their fashion.
Now, you were saying that there was one medic who stayed to wait for the placenta to deliver, but like, what's the, like, if it doesn't deliver in the next couple minutes, just go ahead and leave?
Yep.
I've waited about 15 and then left. Yeah.
I mean, if my mom is stable enough to get her onto a stair chair to get her into the stretcher, baby's healthy, mom's healthy, let's just head on to the hospital.
Yeah.
5 minutes is what I'll probably wait around if it's a multi-gravid patient. That thing should come pretty easily. If you're waiting any more than 15 to 20 minutes, you're wasting time.
Yeah.
Sorry.
Yeah, go ahead.
Would you stop, like, if she starts to deliver placenta?
Because there's nothing to do for it.
Okay.
You just let it deliver naturally, and then the real thing is going to be the assessment afterwards to see that the placenta is all together, it's intact, and then to see if there's any hemorrhage.
And
Those are things you can do
Back it while
while
you're driving.
And the one I'm remembering from Brumby Lofts, I mean, we cut the cord, the baby's already on the way. I was taking care of mom. We'd waited about 15 minutes, two or three fundal rubs, still no placenta, packaged her up, made it from Brumby Lofts to Northside Atlanta, placenta still hadn't delivered.
Yep.
Is it easy to tell when, I know sometimes with parts of the placenta be left in, they'll get torn and left in the woman. Is it easy to tell if it's like that?
Yeah, so the placenta will deliver, and you'll notice that there's like a chunk missing from it or something.
Okay.
So yeah, and you will give them, you'll bag it up, and then you'll give that to the nurse or whatever, ask them where they want it. And then you'll say, hey, I believe there are retained placentals here or whatever. Let's see, we're looking at, if we're gonna have an imminent delivery, what can predict that, how far apart our contractions are, how heavy they are, etc. Water break, you don't have to have your water break to deliver a baby, like we're talking about, that kid can be delivered in call, in the amniotic sac still. So that is not a prerequisite for active. This one, do you feel like you need to have a bowel movement? That's going to be a big one. I've discovered many women in active labor on the toilet because they feel as though they have to have a bowel movement. And then, lo and behold, a few seconds later, they're pulling a baby between their legs. You say, hey, congratulations, you're a mom. At that point, you just kind of do your normal neonatal stuff, warm, dry, stimulate, check on mom, make sure she's still doing fine. You'll sit there and you'll wait for the cord to stop pulsing before you clamp and cut.
Why is it an issue for a woman who has had a C-section previously to give birth vaginally?
So they call that a VBAC, vaginal birth after cesarean. It's typically not an issue these days, but if they've had cesarean before, they have a probability that they'll need another one. So like, for instance, my mother had 3 cesareans because we all have big heads. We couldn't fit down the birth canal. So that could cause a OB emergency. So if you've got a kid that has an arm hanging out because they won't fit, that would be a problem.
The way cesareans were done up until, I want to say, the early mid-1990s, that could prevent future vaginal delivery. Not so much of an issue anymore. Like Mike was saying, the technique has changed surgically to where the way they do cesarean sections now, it is much easier to have vaginal delivery in the future.
Yeah, I thought originally, and this is probably back way, was that because they did the surgery, cut the muscles, that the muscles were not necessarily as intact or as strong to be able to help the contraction.
Yeah, I don't know the pathophys, but that makes absolute sense of why that would work that way.
Let's see, if the patient says she's about to deliver, has to move her bowels, feels the need to push, you can expect a baby coming. Let's see. So on the BLS level, once active labor has begun, you can't stop or slow it. There are medications that can be delivered via an ALS unit. or via physician's order, like from a receiving or from a referring hospital. Say you're going to North Georgia to pick one up to come down to Northside Atlanta, they may be on a Pitocin drip, and that's something that will slow those contractions. It will slow down the delivery of the baby. Yep.
Would you try to get a IV? I mean, not necessarily us, but would you just to be prepared?
Oh yeah, absolutely. You're
For
going to
the
start.
mother,
yeah.
absolutely. Yep, saline lock or a bag hanging at TKO.
Yeah.
Because if things go south, imagine trying to get an IV on a hypotensive individual.
Yeah.
So go ahead and place that IV first, and then you've got it accessed.
And to that point, if IV start in the field, you get what you can get.
Hey man, if it's a 22 in your thumb,
Yeah.
I don't care. I've got
Ideally,
access.
and would look like a rock star to the L&D team if that patient shows up with a field started IV in her forearms. You want to avoid wrists, you want to avoid hands, and you want to avoid ACs. Why? Because when you push, you're going to occlude those IV sites.
Do you do anything different for moms who have strep B?
No, you just report it and say, hey, they're strep B positive, then they'll give antibiotics.
Okay.
There's your OB kit. It's got all sorts of stuff in it. There are many like it. Yeah, you got that.
Yeah. But this one is
one's
mine.
mine. Yep. On the back of it, or on the front, it's going to have a parts list. You just say, okay, I got that.
And to look like a rock star EMT, woman in labor, that OB kit comes out of the cabinet and goes on the back of the stretcher. Why? Make it all the way to the hospital and you get stuck in the elevator. It's happened. Babies have been born in the elevator or delivered in the elevator at Kennestone going to the second floor L&D, and that's not a good place to not have your OB kit.
So when we're getting ready for delivery, drape appropriately. Hopefully you have a private space, your bedroom, your bathroom floor. I'll just say that if you're on the bed, there is going to be a big old mess. So that person might not want to be on their mattress. If you have extra towels and stuff, tuck them up underneath their butt. You want their hips up just a tiny little touch, and make sure you have plenty of dry materials to warm, dry, stimulate the baby.
Yeah, babies are born wet and they're born cold.
Oh God, they're so slippery too.
There's a reason there are so many drop the baby jokes.
Yeah.
They are slippery.
Pick it up.
Yeah. Yeah, day one, you drop the baby, pick it up.
This whole sterile field situation,
Nothing about this process is sterile or
No.
even close to it.
not at all. It's not a sterile procedure.
You want to be as clean as possible.
An aseptic process, where you're trying to stay clean, medically clean, but it is not a sterile situation. It's not that we're doing surgery. You go into the L&D unit, you're going to see docs who are doing the C-section. That is a surgical procedure, so they will maintain sterile field and sterility. This is an example of draping. Yep, if your partner is down for it, you don't need them down in that private area. Have them up at the head coaching. If there's a partner who is involved and they would prefer to coach, let them do it. So timing of contractions, it's from when they start feeling it until when they stop feeling it. And then you want to know the time in between as well, so you can time how far apart they are. So this is what we're talking about with the gentle pressure on the perineum, so that we don't have that laceration. They may poop on you, they may pee on you, whatever. We're talking like full-on PPE now, okay? So this is one of the reasons why. Do not poke your fingers in the newborn's eyes or fontaine. Like, who does that?
There is a reason they give you a pair of pants and a raincoat.
Fair.
Because you never wear the pants for nothing. Just keep them with you in case of delivery.
when it comes down to getting the baby packaged for transport, the foil bunting goes straight to their skin. It's strange, but that's what you want.
Yeah.
So it's like aluminum foil almost that comes in your OB pack. You want that immediate, it's a space blanket.
Yeah, for
You know
your
those?
hikers, emergency
Yeah.
prepper types, it's a
Yep.
space blanket, yeah.
It reflects the heat.
Yes, exactly.
That's
And
the
then
reason
you
why.
wrap that in a blanket or towel.
There should be a hat with your OB kit. If not, you can make one out of towels or sheets or whatever. Basically, you want to keep this baby warm because they are wet and they don't know what extrauterine life is.
Yeah.
So they cannot thermoregulate for themselves. They've just been having mom do it for the last 9-ish months. So keeping this child warm is important.
Yeah. To jump in real quick there, from Dr. Mike's lecture, everybody in our industry repeats peds babies are not small adults. They're not small. Well, they say that, but it begs the question, what are they? If you remember your high school biology, stages of life for an insect, and essentially your newborn is larval. They are the larval stage of human development. They don't have fully functioning kidneys yet. They, like Mike says, they can't thermoregulate. So we need to take those things into consideration. Keep them warm. That is important. When you get to AEMT and medic school, you'll learn one of the causes of cardiac arrest is hypothermia.
So this one, if you've got that baby that's in call, unruptured sac, you'll have to puncture it. Expect a huge bunch of juice to go all over the place. Have towels, sheets, whatever to absorb it. You don't want to use like a pocket knife or the scalpel that's in the OB kit, nothing like that. If there are metal clamps or forceps, you can use those to puncture the sac and then open it with your fingers. Or you can use, what did it say right there?
Tear it with your fingers?
Tear it by twisting, yeah. So you like kind of take a pinch, twist, rip if you can. When it comes to suctioning, we no longer routinely suction newborns, but if it's necessary, mouth and nose. So
That's test question, mouth first always. And you're using what? The bulb syringe that's in the
it's
OB
in your
kit.
OB kit. Yep.
Always suction mouth first, then nose. Why?
The baby always
Aspiration risk. If we suction nose first and they take that first big breath, they can aspirate. Always suction mouth first.
If you've never had to use one of those bulb suctions, you kind of squeeze down on it first, place it into the mouth, then release the pressure, which will suck the contents into that bulb syringe. You place over to the side, go and expel all the crap, then you go back for more if you need to. This is a nuchal cord, so umbilical cord around the neck. This is an absolute emergency. A lot of times it will be wrapped more than just once. All these things are BLS level because we can do something about it. What you're going to try to do is you're going to try to get a finger up underneath that nuchal cord and slip it up over their head so that it releases the child from that, kind of boa constrictor grip. First delivery I ever attended as a medic student, the doc tried to do that in the ED and ruptured the cord. Blood went everywhere, and then it's a big risk for infection, etc. Because that's a huge open wound for the mother and for the baby.
Putting his finger in?
So trying to get it up over, it just went.
Cardinal rule of delivery, you do not pull on the baby, you do not pull on the cord. So what you're trying to do here is gently slide the cord back over the baby's head.
So if you cannot get it up and over, slipped out, then what you'll do is you will clamp, cut. What we really need to do is get that baby breathing, essentially. Get them used to extrauterine life.
Ooh, breech and nuchal cord here. That sucks.
Yeah, that does suck. No, thank you. So once the head is out, then you're going to deliver one shoulder, then the other. What you can do is you can gently do a little like corkscrew rotation if one of the shoulders doesn't want to deliver. And just basically the baby's going to come into this hand or onto the stretcher or wherever you may be. Oh, this stuff, vernix, whatever that second word is, that's the white waxy material that's on these babies that has protected them from getting waterlogged while they were in utero.
Quesiosa?
Yeah, that stuff. So don't try to wash that off. It'll eventually get taken care of in mother baby. Just warm, dry, stimulate.
Is that the stuff that kind of looks like cottage cheese, like dry, waxy cottage
Yeah,
cheese?
I know you'll see it in like the folds and everything like that. Yeah, full waxy material. Warm, dry, stimulate the kiddo. Wrap the newborn so only the face is exposed. That's where you're talking about potentials for hypothermia. If mom is able and willing, let's do skin to skin because that will promote her healing as far as oxytocin releases, and that will help with the uterus becoming firm again. If she wants to breastfeed, go ahead and allow her to do that because that again will release that oxytocin, which will help with the uterine firmness, and you got that skin to skin, which is the warmth. Yeah.
And we all oxytocin, which is a hormone. Excellent. Do you know what it does?
It's the bonding hormone. So you get oxytocin releases from breastfeeding. It promotes bonding between the mother and the child. You get it from hugging your partner. You get it from all sorts of different routes, but it is like that bonding kind of creating a unit hormone. Yeah, so APGARs, let's talk about those real quick.
And the majority, for at least anecdotally for me, the majority of births I've been there for, actually, all but one, baby comes out and screams bloody murder, and that's a beautiful, beautiful sound. Using them lungs, opening that airway, and APGAR is 8, 9, or 10.
I like those.
Yeah.
Cutting after 60 seconds, is that just the time?
That's an arbitrary number that they chose.
Oh, okay. I didn't know if it was like
Wait until the cord stops pulsating.
Yeah.
a... Okay.
You can hold on to that cord and you'll get the baby's heart rate.
Yep. Best way to get a fetal pulse. Or newborn pulse.
Yeah, or you can put your stethoscope on their chest and count how many times it beats in 1 minute. But yeah, if you hold on to that cord, it will slowly, after a few minutes, slow down. Now at that point, it is not the baby's heart rate that is slowing down like that, but it's just the transfer back and forth from mom to baby. That is slowing, and at that point you can clamp cut. Yes, ma'am?
I have a question, not to go backwards, but
No, go ahead.
the oxytocin, that's a hormone, but it's also put in medicine?
The medicine is called Pitocin.
Yeah, because I had that and
Yeah.
it reduced my labor.
Exactly. Just like the hormone released in fight or flight is adrenaline, and when we put it in a vial and dose it as a drug, it's epinephrine. Oxytocin is the hormone, Pitocin is the drug.
So like I was talking about, you can use it to induce labor if there's been a delay, but you can also use it to delay labor as well if you've got a Pitocin drip at a low dose. So yeah, wait till the cord stops pulsating or reduces significantly. Clamp about 6 to 8 inches from the baby's abdomen. You will put about 1 inch or 2 inches in between the two clamps and cut, or with scissors that are included, or with a scalpel. Be careful because that umbilical cord is super fibrous.
Yeah.
So getting through all the different layers of it may take a couple cuts. And imagine, you've got a wet baby, you've got wet hands, that scalpel, very dangerous for the sharps consideration.
What about shoes?
I'm sorry?
What about shoes?
I wouldn't want to do that because they're probably dirty.
Yeah. Filthy dirty.
Yeah.
Um,
APGARs.
Biohazard dirty. Yeah. Let's talk about APGAR.
You'll see it up here. You get 0, 1, or 2 depending on the category. This is created by
Dr. APGAR.
Dr. APGAR, yeah. So she is a neonatologist and created this one to deal with the transition from intrauterine to extrauterine life for these babies. 0 is going to be your worst, 10 is your best.
Yep.
So you do APGARs at 1 and 5 minutes after birth. Hopefully they improve. If they do not, then we need to intervene. If you got a poor APGAR, then you definitely have to intervene immediately.
And what is a poor APGAR?
I'd say 5 or less. I don't know what it is officially in the text.
The textbook is right there, less than 7. Most babies will not be born at 10.
Even the best babies won't get a 10.
8 or 9. 9 is great. 8. Most babies, there are some periods of apnea. There's transitional apnea, then terminal apnea. There are natural periods of apnea that occur when the baby is moving through the birth canal. So most babies will be born with a level of what we would call peripheral cyanosis. See cyanosis in the fingers and toes. And that's the reason most babies, that and maybe a little delayed respiratory effort, I would say, are why they're not a 10.
When we're going through this, if we are having to resuscitate a baby, ventilations are going to be most important.
Here.
Oxygen, and we only have 100% FiO2. When you talk about neonatal resuscitation, you try to start with room air and then increase. So you could start with just ventilations on room air. This will help them transition to extrauterine life. Their SpO2 will not be 100% to start. They start somewhere around 60, and then within 10 minutes of life, they should be in the 90 range. Go ahead and slap that pulse, dry off a wrist, and put that pulse ox around their wrist. There will be extra slimy, so make sure that you get that thing put on there really well. You can also use a foot, that little tape pulse ox that we get. We use that one for these kiddos. It'll also give you great heart rates that you don't have to, sit there and listen for a full minute or try to palpate like a brachial pulse or something.
What would you say for the APGAR, the typical 1s and 0s and the emergent ones? Like you were saying, appearance is
Any
you're
0,
not concerned if it's a 1.
any 0 in any category is pretty concerning.
Okay.
Yeah, 0 is going to be a problem.
Yeah.
So what are your typical ones?
You're going to have these blue extremities. You might have a low-ish heart rate. And then the respiratory is kind of where those ones that I'm going to be concerned with mostly. Because those are things that I can really affect.
Right, and the other ones are going to follow those.
Yep.
If your baby has a low heart rate and low respiratory effort,
Once you start ventilating them, that
should perk them right up.
Yep.
Yeah.
Their ventilation will improve. Their ventilation on their own will improve. All those things should come up. So your APGAR should be better on the second one. Placenta delivers itself within a few minutes. If not within a few minutes, we're going to the hospital. Don't pull on anything when you're delivering a kid. Just don't do it.
It's not a good look.
Nope. Post-delivery care, it shows 2 hands for this fundal massage. I found that taking a fist, placing right on the on that fundus, and just pushing and massaging, it hurts. I'm sorry, it does. I apologize to my patient. I say, but this is what your uterus needs right now because we have uterine apnea. It is not firming up the way that it's supposed to. So what I'm doing by this is I am preventing hemorrhage. There I am. I'm grinding into their abdomen, unfortunately.
I was trading palm heel.
Yep.
Yeah.
This is what they need. So time of birth, you don't need to announce it over the radio. Just look at your watch, go, cool, time of birth is XYZ. And if you say it out loud, then there are more ears to hear it. So you are more likely to remember, and if you do forget, maybe your partner remembers it. More than 500 mils of bleeding is considered hemorrhage. That is significant bleeding. And then if there is, bleeding after the delivery of the placenta, that's what we would worry about with, maybe there is retained products of conception up in there. And then, if there's been more than 30 minutes, that's when you're going to have a retained placenta that needs that DNC, dilation and curettage. It's that surgical procedure we were talking about. All right, so neonatal resuscitation, which I just barely touched on. Basically, it's going to be airway and ventilation. These are going to be things that get that baby headed in the right direction. Warm, dry, stimulate, if that doesn't do it for you, then you're gonna move right on to ventilation with room air via BPM.
So, baby is delivered. What does warm, dry, stimulate mean? Dry, preferably towels. If sheets is all you have, rub the chest, rub the back. Rub the chest, rub the back. Extremities, top of the head, rub the chest, rub the back. Hopefully by then, your little one is screaming bloody murder. That said, please do not hold them upside down by the feet. Please do not smack them on the ass. This is in the 1950s, you know. We've grown up a little bit medically since then.
Yeah, our tactile stimulation is the drying situation. These kids have been in a nice hot tub for the last 9-ish months, and then they come out and imagine like the worst feeling in the entire world. They're getting it right now. As we're rubbing this thing on them that probably feels really rough to them. To us, it's like, oh, it's a nice soft towel. To them, they're like, this is the worst thing
This
ever.
is sandpaper. Even think.
Yeah.
Warm, wet, dark,
tight. Their entire life.
Yeah.
Their new life, but it is. So, okay, yes, question.
So what are we doing with a premature baby?
Same stuff.
Yeah.
Warm, dry, stimulate.
So, places like Bartow, like, there, I don't know if they even have an NICU at the Cartersville Hospital. What do you do in a situation like that? So you have a baby baby or super emergency, or like the closest.
Well, the fact is that they do have an L&D, so I take them there
Yeah.
if I've got a baby.
You've got a decision tree here. This is a preemie baby that is a high risk. Mom knows preemie. Mom has been given prenatal care, and like Mike was saying earlier, actually preemie has already. Mom has probably already been admitted and is in the hospital when that preemie is delivered. If you're delivering a preemie baby in the field, there is a high degree of all of these other horrible conditions that we're talking about: possible abuse, possible minor child giving birth, drugs and alcohol abuse, all of these factors. Your index of suspicion is going up there. What do? Same stuff, and get them to the closest L&D you can.
So the good thing about that is that if you get them to a unit that has L&D, they can arrange for transfer.
Yes.
And they are specialists in neonates.
Yes.
You know, they might not have a NICU, but they're good with newborns. So, and there's a lot more hands there. So they can take care of it and then get them off to a specialty center. So this golden minute is important. So that's when you're want to get your APGAR at 1 minute. This is where you want to slap the pulse ox as soon as possible so you get that heart rate and SpO2. And then you want to just kind of get the general appearance of the child.
What do you do if your first minute APGAR, the P in your APGAR is about 40? Chest compressions.
Bingo.
You start CPR right there, because if they haven't arrested, there's really no way they're...
And under 60, you do it, right?
Yeah.
Yep.
Yeah.
If a baby's tiny enough, can you do like where your hands are wrapped around the baby's
Yeah,
thumb?
you do that 2 circling.
Yeah, 2 thumb and circle.
Yep. So if you're in a like big resuscitation situation, they actually want the person doing compressions at the foot of the baby, so that everybody else is up around the head and they can do all those interventions. Just a little FYI. So the baby should be getting breathing within 30 seconds. Heart rate should be 100 or higher. If it's not, then we're gonna work on ventilation oxygenation. There's your steps for neonatal resuscitation, the initial ones.
What's our compression to ventilation ratio for a newborn?
3 to 2.
3 to 1.
3 to 1.
3 to 1.
You got it. Pretty close. Yeah.
Close, yeah.
So one of these ones that I was mentioning, so to evaluate heart rate for the kid, you can hold on to that umbilical cord. Once you clamp and cut, you can actually hold on to their stump, and that will give you their heart rate. You can grab the brachial artery up here. That's my favorite because it's easily compressible along the humerus, so you can get a really good, accurate rate. or you can auscultate by putting your stethoscope over their left chest. And a trick that my medic instructor taught me was it's really hard to keep up with that when they go boom, 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 boom. So what he does is he sits there and he taps his finger. Every time he hears it, has somebody else count how many times his finger has tapped in 60 seconds. When it's one respiratory situation or bystander CPR, they say hands only, compressions. This is the one time where ventilations take as much precedence as compressions, because the most common reason for a cardiac arrest in a newborn pediatric patient is going to be a respiratory arrest or failure.
What is the, I don't know if it says it, is it still 1 breath per 6 seconds, or is it faster?
So you'll do 3 compressions, 1 ventilation.
Are you asking about rescue breathing?
The rest, like, do you know how we were like, don't squeeze too fast?
The infant.
Yeah, the infant neonate BVM once every 3 seconds. And
so,
still a gentle squeeze.
Yep, just gentle.
Yeah, we tender new lungs. We don't want to risk barotrauma there. You're still bagging, but about once every 3 seconds.
It'll probably be a little bit quicker than 1 full second.
Yeah.
Over that ventilation, maybe a half second or so.
Yeah.
Children, pediatrics, infants, they have a shorter inspiratory time to begin with, typically between 0.5 to 0.7 seconds.
But what are we looking for? Absolutely, chest rise.
Neck staining, you'll suction out before you provide any ventilations because you don't want to push that nasty poo down into their lungs. You got your APGAR, which we've talked about. 1 minute, 5 minutes.
Well, let's talk about that real quick. Grimace, cries on stimulation. How are you going to stimulate that baby?
Bottom of the foot.
Yep, you can flick the bottom of the foot. When you're drying them off, that should be stimulation.
Yeah. Appearance kind of obvious. We're looking for cyanosis. Activity. That can be kind of a tough one. How would you assess that?
I mean, they wiggle, but they also try to grab
Yeah,
you and stuff.
tug on the baby's arm.
Yep, if they're pulling back towards themselves,
That's a 2.
absolutely appropriate.
Yeah, that's a 2.
If you do your APGAR at 1 minute and you've got 7 or less, then you need to intervene. If it hasn't improved at 5 minutes, continue your interventions and transport rapidly. And
Yeah.
hopefully you never have to deal with any of these presentations, but they do happen, so we're going to cover them.
Yeah.
So breech is when the buttocks are coming through first. Oftentimes the legs are up against the chest. So that can cause trouble because if the butt is out and then the cord gets compressed, baby no longer has the blood or oxygen supply.
Right. So in the field, again, our decision tree, things we intervene on, head, we can deal with a head. Butt, we can deal with a butt. 2 feet. Anything else, diesel. Here we got a good example of breech. What do you think that is? That's not a baby's head.
No, it's a booty.
Yep.
What would you guys say that this stuff is right here? Yep, that's meconium staining.
Mm-hmm.
So that's from distress on the child in the
Yep.
birth canal.
Yep. Butt and legs.
Wow.
Yep, there he is.
Yep.
He is coming out on hardwood.
It's like a springboard diver.
Yep.
Yep.
Our-
There it goes in.
It went plop.
Yep. Feet
Is
went
that
plop.
normal?
That's what's that?
That's the umbilical.
That's the umbilical
Yep,
Is
cord.
that the normal color?
Yeah, ish. Look at the feet though. Is that good color for the feet? No. We are cyanotic. And we've got an arm now.
His hands don't look too bad,
No. And mazel tov.
There we go. Hooray.
Yeah.
Look at those head veins.
Yeah.
Perfect for a cannula. So if you do get a presentation like this, we're worried about that airway being occluded via the birth canal and compression. So what you want to do is you do SPOC, live long and prosper. Go ahead and put your gloved hand. This is the time that you're allowed to put a gloved hand into the vagina. You go up there and you make space for the baby to have air from the outside world. So you're creating an air passage for them. Imagine them as like a spelunker, a caver who is in a collapse. You want to give them a passageway for air. So that's what you're doing for that.
Would the mother be on her hands and knees?
So there is, yes, a hand-knee position, and that would be a great idea for this presentation. Yep. Here is a limb presentation. Those
1
suck.
foot.
We can't fix that.
No.
Get them to the hospital.
Yep, you fix that with diesel.
If you have ALS nearby, snatch them up real quick because there are a couple things that we can do to kind of try and slow the birthing process, but not a whole lot. We are not a fix-all. The hospital is going to be the one that delivers this kid.
And you would just literally grab the medic into your truck and go.
Yep.
Grab your
So
drugs,
if I
grab
have
your monitor,
paramedic
let's
on
go.
scene, I say, get your drug box, let's go. So what we would try to do is give them some medications to kind of slow that that process.
If the mother wanted to go to,
We're going to nearest.
Yep,
You don't get a choice anymore. I'm sorry, this is an emergency.
yep.
Straight up. I understand your birth plan was to be at Northside Atlanta, but Cobb Hospital's 3 minutes away.
Yeah.
You're going there.
Your plan became null and void when your baby presented with one leg.
Yep.
Yeah, sorry.
And that's how you should be.
Yeah, it is. I mean, you got to be cut and dry about that one. You're like, I'm sorry, man, but we can't do that. This is an absolute emergency. We're going to our nearest ER. So you got prolapse cord. This thing could be complicating, similar to the breech presentation where you have to create a passage for their airway. You have to create a passage for the cord so that it's not being compressed because that is their lifeline.
Yeah.
Okay?
But you're not taking the cord out.
Negative. This is as if the cord has presented
Yeah.
itself.
Yeah, we don't have an arm, we don't have 1 foot, we have a loop of cord.
Yep. So this is, again, you take that gloved hand and you take the pressure off of that cord by creating a little passage for it.
Maintain a pulse in the cord, keep it moist.
I mean, if they try to go that way, I mean, if the baby's coming, it's coming. But what will happen, though, is if you deliver that child, then the compressed cord is no longer an issue.
Gotcha.
This one says lie supine on the foot of the cot with legs up. Higher than the head. Yep. Legs up. Or you could do the knee chest position, which is one that this young man was talking about. It's on all fours. It's hard to transport in that position and be safety conscious. So use your best judgment at that point. Maybe it's best to put them supine and then have that gloved hand creating a void for the cord. All right, I'll be right.
We have crowning. Yeah. You got to do what you got to do, but this is at this point the baby's coming. This is why you want to do this in the hospital.
But if you're in that, hypothetically.
So I walk in the door and that's what's going on.
Would you rather be in a bathtub doing that, or?
It's whatever. It's
Yeah.
It's a last thing about
It might be too slick or something, and you have a choice.
There he goes. Hooray!
Normally, right after you get those two shoulders out, you
Yeah,
just,
that's a big
So what do we
boy.
think about his color?
that face is ugly.
Bad news bear. What APGAR would you guys give this kid?
Well, let's see, he's not.
Can you pull up the screen again?
Yeah, he wasn't making noise, he's not moving.
We don't know if it's making noise because
He was.
Cyanotic on the extremities. So 1, 2,
Probably 0.
We got appearance, pulse, grimace, activity, and respirations. So for appearance, what are we giving him? A 0? Okay.
because it wasn't on his.
So for pulse, I'm going to say he's a 0 or a 1. We'll give him the benefit of the doubt and call him a 1. Grimace, 0. I agree with that. So activity, 0 because he's limp. And respirations, he isn't breathing. So we got a 0. That's an APGAR of 1. I am upset with that. I don't like that.
Yeah.
That kid needs some immediate
He
resuscitation.
starts chest compressions and ventilations 3 to 1 immediately on
Yep.
the kid.
I'm not waiting around for that. I'm not waiting for a minute to calculate this stuff. I'm just noting in my mind what he looked like, and I'm going to do the numbers later. I'll work on resuscitation.
Yep.
What about the cord? I mean, you're gonna work with the cord
That
attached?
was home birth by
I would.
herself too. That is,
Because at that point, he is getting oxygenated blood and, he's
Yeah.
getting, you know, there's circulation going from mom. The lower your APGAR, the worse the outcome is possibly gonna be.
Yeah.
But like, I can't imagine some of these, like, unless you've got at least lungs and like your pulse and your respiration, I don't know how, you couldn't have reminiscent activity.
Exactly.
That's what I was saying.
Yeah.
That's
yeah.
why I said I'm looking at appearance, pulse, and respiration.
The others
Reminiscent
follow.
activity will follow.
Yeah.
Those are the important ones to me.
She sat there
She was pulling.
for, minutes.
She's also not a trained rescuer.
Yeah.
But I mean, pulling in, would that be one of the reasons why the respiratory rate and everything else?
You're leaving the baby in terminal apnea too
Yeah.
long.
Yep.
Yeah.
Because they're being compressed in that vaginal canal. They're not being able to breathe at that point because you are getting swished through your birth canal and you have no room for that ribcage to expand or for that diaphragm to drop. So that could be part of it.
So what would you do if you were there? What would you do?
Immediately start, I would suction the mouth. I would start with ventilations and chest compressions.
Yep.
If it was me and my partner, I'd say, hey man, you start pumping on their chest, 1 every 3, and we're just gonna do BLS until everybody else shows up.
Yep.
I guess that's the
Would you have
biggest.
done the birthday any differently?
I'm sorry?
Would you have done the birthday any differently?
Yes, absolutely.
Yeah.
Yeah, she would have been on her knees or anything like that?
Yeah.
Oh, yeah.
Yeah, if I had walked in the, say, partner calls 911, I walk into the bathroom and see her right there, okay. Lay down, drape, towels, and deliver the baby. Are we crowning yet?
Coaching her to push like hell.
Yeah,
You know,
yeah.
like, lot of different things would happen.
And I guess one of the other problems is the fact that she just gave birth and then has to try to do resuscitations on the baby.
Yeah.
I'm like, that's
Yeah, it's unfortunate, but
Yeah.
that's the situation you get put in sometimes.
That's kind of the worst of all worlds right there.
Right.
Yeah, in terms of what you're gonna have to assess and deal with.
So as this is going on, we'll talk about spina bifida real quick. That's when there is an opening along the spinal canal. There's going to be a protrusion of the meninges. Put them on their stomach. This is the baby, by the way. Put them on their stomach, cover it with a moist dressing, transport. Keep them warm, just like everything else. Twins occur once in every 30 births. They will be smaller than a single baby. Oftentimes they will be quote unquote premature. If they are anything greater than 36 weeks, that's a term baby. If they're less than that, they'll probably spend some time in the NICU, growing and feeding. They have premature lungs, they're not fully developed. There's a chemical, it's called surfactant. It's what keeps your alveoli open when you aren't breathing. So these kids don't have enough of that often because that surfactant is created within the last couple weeks of gestation. Babies who come late or post-term, greater than 41 weeks, at that point they're going to induce you or they're going to come in and take the baby. And when I say take the baby, they mean a planned Cesarian. You don't want to have your kid in there for too long because you can cause infection to the mother, to the child. They can grow to be too big, which could be detrimental to mom. Stillborn kid, those suck. If you can tell that the child is definitely dead, not like, this one here, which was probably good at one point. Like if the child is gray, that would be an obvious fetal death prior to delivery. If there is this foul odor, if there's decay of the child. So this is going to be a really tough one for you as a provider and for the mother. You may have to transport that tissue to the ER. This one I'm calling med control and asking, hey, what do you want me to do? You may leave that fetus at the scene for coroner to come by and collect. That's when we get into custody of the scene. Most of the times here in Cobb, we can leave it with PD. Document who you left the scene in custody of. Fundal massage, if you got bleeding. External, use a pad. Note how many pads you got.
Are we allowed to use
Are there?
I guess so, it's a stupid question, but AED pad, all the gauze we can.
Yeah. I think an AED pad is a great one because it absorbs pretty well.
Like the 35 wells or whatever, trauma dressing.
Yeah, for sure. Do not discard any blood soak pads. Bring them into the hospital with you. After birth, you have risk of emboli, whether it be an amniotic emboli, fat emboli, a DVT. It's just one of the things that comes along with being pregnant, unfortunately. So you arrive on scene for somebody, who has a 4-week-old who has dyspnea, difficulty breathing. You're like, huh, that's really weird. That doesn't fit like any clinical picture that I'm thinking of. Why are you like a 32-year-old who has like severe dyspnea? Consider an pulmonary embolus. Those people can turn real quick on you, unfortunately. Like they can go into arrest like that. So,
Yeah.
So, how do you talk? I know it's probably going to be different times. So
have you talked about like fetal demise?
Yeah, with a mother who's saying, "What's wrong with the baby? Why?" You know what I mean? Who's just
This is the one where you have to use the words dead, died, instead of passed or has gone to a better place. Say, I'm sorry, but your baby is dead. Your child has died. There is nothing more we can do. There's nothing more the hospital can do. I've got med control on the phone right now, and he's telling me that there is nothing to do for this baby. I'm so sorry for you. Is there anybody you want me to call right now? Do you have family? Is there clergy? You know, you just got to consider all those kinds of things with any kind of death notification.
Would we go with one at that point? Or just
That'll be coordinated through 911.
Yeah, your dispatch is taking care of all that.
Yep.
So we want to transport the baby
Not likely.
at the hospital.
Nope. It's not likely, but you know, depending on your jurisdiction, whether you go work somewhere else, they may have ME at the hospital.
Oh, she's gonna say that. Yeah. I think it's now. So it's a really big push. Really big push. That's it, go on.
Good girl, well
Big
done.
push. Big push, that's it, keep going.
Gonna be out.
Keep going. Keep pushing. That's it, darling, well done. Keep going. Keep going. Push going. That's it. That's it, he's coming. Oh my god.
Oh my gosh. Oh my goodness.
Ready, Simon? Ready?
Well done.
Keep them really nice and warm.
Oh my gosh.
Children are not small adults. I disagree with that 100% because they are. You just have to know how they're different. They have the same anatomy that we do, it's just shaped funny, okay? They have big noggins. Like, you see them, like, they are top heavy. They will fall the hell over. The epiglottis is more anterior in the airway, and it is big and floppy. So when you go on, if you go on to become a paramedic and learn about laryngoscopy, you'll know that that thing is just going to drop right into the middle of your field of view, and you just got to expect it. Additionally, they have less subacute tissue, so they can become hypothermic more rapidly. And with that big old head, you can expect greater incidence of head trauma. So, You do have to learn how to approach them differently.
Gesundheit.
So the way that I'm going to talk to a preschooler is not the same that I will talk to a 10-year-old, you know. My best assessment tip for you guys is to learn your from the doorway assessment. I talked a little bit about it earlier when I was saying when we look at Peavy, he's, you know, rosy cheeked. He's looking at me when I walk in. I can tell that he's A&O times 4, GCS 15, and that he's doing pretty good. He's pretty stable. Until I get vitals, I don't know 100%, but I know he's doing all right now. He's not about to keel over on me. Same thing you can do with the little kids. You come into the house, this is their domain, and you are coming into their house, which is abnormal. You're a stranger to them, and depending on the developmental age, they may recognize you as a stranger, or they may recognize you as, you know, the superhero, or, you know, kind of like you're a person in uniform, and you're kind of like the cops, you know. But as far as assessment for the little kids goes, get down on their level. You got mom and baby right here. I'm going to get down on eye level with that child, because if you are standing over them, that is very intimidating to this individual. They understand that at a young age, you know, even toddler age. So if you can get down on their level and you start with the feet up, you say, hey buddy, how we doing? And, you know, like you just kind of can hold on to their foot for a second. If they allow you to do that, you can move incrementally up their body. Have mom or dad, caregiver, participate in the exam. They can be a great help. Also, distraction is really useful. Hey, what do they like watching on TV? Is there something on YouTube that they love? All right, let me go ahead and get that fired up real quick. Here, Junior, hold on to this real quick. You are caring for the family members as well. That can be a huge stressor. Sometimes these kids are perfect. No trouble in the world. They want to hang out with you because you're the cool person. And then mom or dad is freaking the F out. Hopefully you can reassure them, say, hey, you know what, they're in great hands right now, they look awesome, they're presenting very well right now. I'm not too concerned, but, you know, say, hey, they are great, they are looking amazing. You know, I'm so happy that you called us so that we can come meet your young kid, you know. This is a delight in my day, you know, this is a positive for me. I get to come meet your child. Thank you for that opportunity. That's just a little customer service for you right there. So, absolutely true, calm parent usually results in a calm child. There's a lot of different life stages that happen. These are your main ones. You got infancy, toddler, preschool, school age, and then adolescence. That all have their own like little nuances about them. I would highly recommend, if you decide to keep going in this career field, taking a developmental psychology class. It's wonderful. I don't have kids of my own, but it helped me understand the developmental span of these youngins. Let's see, 0 to 2 months, there's not a whole lot going on. Eat, sleep, poop. That's what they do. 2 to 6 months, they start to become more active. They start to explore. They're trying to roll on their own. So that kind of rolls right into something that can be a tip for you, is that if you got a 6-week-old that mom said they rolled off the bed, that's a lie. That baby cannot roll right now. So knowing that these developmental milestones for the kids can help you create a clinical picture. If I've got an 8-month-old where mom said, hey, you know what, I changed him on the bed. Yes, sir.
So let's say they're 2 to 6 months old, you get that and they roll off the bed. What do you think of child abuse?
Mm-hmm.
Okay.
Yep. As if they're older on that spectrum, getting closer to 6 months, it's possible. You know. But if they say, hey, I've got this 8-month-old and he rolled off the bed, I changed him, then I just turned around real quick, threw out the dirty diaper. I go, okay, you know, it's possible. 8 months old, you know, he's starting to roll on his own.
So like 3 months?
Not happening. Nope. So that's where learning these kind of developmental milestones will help you understand what's possible with these kids. 6 to 12 months, like we're saying, is that they start to become mobile. They'll crawl, they'll scoot, they'll start to walk later on in that spectrum, toddle. And then they investigate their area by putting things in their mouth. That's how they experience the world. Big old dangers of choking hazards, coins, toys. Biggest thing that I can think of are button batteries. So those things are terrible. That is an absolute surgical emergency. You need to take them to CHO. Like
key fob batteries.
Or the one that's in our glucometer, things like that.
They're on CHOA's list of one sip, one swallow, like Tide Pods, touch-up paint, Carmex. Any of these things get inside your toddler, you're going to need a new toddler.
No, you're going to need to take them to CHOA, and they're going to the ICU or to surgery. So these button batteries, what happens is they go down your esophagus, and then it creates a contact because our esophagus is non-rigid, right? So it creates a contact between the front and the back of the battery. It starts to erode away at that esophagus. What's right behind your esophagus is your aorta, your ascending aorta. So this can cause somebody to die very quickly. So it's an absolute surgical emergency. Even if they say, hey, I don't know if they did, take them to CHO. Let's see.
So even if we're in Cobb, that happens if they didn't do
Yep. Because Cobb Hospital, Keystone Hospital, they aren't going to be able to do anything for that patient. They're going to do an x-ray, then they're going to call CHO.
Other than stabilize them and transfer them to Scottish or Eggleston. Probably Eggleston if they got to do surgery.
At that point, you have just burned time, where this thing could have been eaten through their esophagus into their aorta. That's bad news bears, my friend.
What about magnets?
Magnets are one of the ones. It depends on what kind of magnet it is. Not as dangerous as this button battery. From the doorway, assessment, have the caregiver hold on to the kid, sensory comfort. Warm your hands before you touch these kids. That goes for any patient. If you have persistently cold hands, you can go ahead, rub them up before you go and you touch somebody. You say, hey, I'm sorry, I've got really cold hands. I'm just trying to get them warm before I touch you. Let's see, endoscope, not a huge thing. If you want to, you just rub it on your hand, warms it right up. Absolutely do painful procedures at the end of the assessment. When I'm getting vitals on a kid, what I'm going to try to do is I'm going to try to count respirations from a distance because that hopefully will not change when I'm observing them. Then I'm going to get a heart rate and an SpO2 hopefully. Maybe I'll do a blood pressure depending on the size of the kid and their cooperation level. And then I'm going to do a temperature blast because up under the arm is not terribly comfortable. It's not the worst, but if I'm having to do a rectal temperature on a child, do you think that's going to affect their heart rate, their respiratory rate, and then their blood pressure? And their trust? Yeah, that's an uncomfortable procedure. It's not the worst in the world, but they're not going to like it, and it's going to jack all those vitals up. We got a toddler that's 12 to 18 months typically. I would go as far to say that up to 36 months I would consider a toddler, and that's right into preschool age as well. Yeah, they're typically not afraid of strangers. They're the coolest kind because they'll walk up to you and be like, hey, what's your name? I'm like, hey, I'm Mike. Who are you? You're pretty awesome. They're pretty cool. They're fearless. So you might have broken bones with them. They'll jump off the couch thinking that they're Superman, and then don't think twice about it. So they don't have those molars to chew everything very well. So these are the ones that will get a grape or hot dog stuck in their trachea. If you have kids or you watch after kids, your family has kids, just encourage them to cut those into tiny, 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 tiny pieces. Grapes and sausage are just those ones that always come up. If you do have that, what's going to be the treatment, y'all? Yep. Heimlich maneuver. If they go unconscious, you lay them on the back, start CPR. So these toddlers may have strange danger. They may be cool and like, hey man, what's going on? We're going to do the Wong-Baker or FACES scale for their pain. That is observable. Or you say, hey, which one does this feel like? And you got those faces and say, and sometimes they need coaching with that. You say, this smiley face is no hurt at all. This middle one, like 6, hurts pretty bad, and this is the worst pain in the entire world, and you got crying face because of your mom and dad. So putting it in their terms is helpful. Yeah, they may not like you because of shots that they've been to the doctor with. So preschool, 3 to 6, like I was saying, up to 36 months is kind of where I cut off the toddler. And then we go into preschool age. These ones are also very explorative and have a great imagination. They can usually follow directions and play along, participate in the exam if you build that rapport with them. Just takes 30 seconds to 60 seconds that you can tell that it's going to go well or it's not going to go well. So.
At that age group, it's helpful to have your favorite superhero, your favorite Disney princess, your favorite dinosaur.
If you know these things,
yeah.
You will get in with these kids. You'll get over on them so easy. You're like, hey man, do you like Paw Patrol? What about PJ Masks? You know, just something that they are familiar with. So Octonauts, great. What's your favorite guy? Even if you don't know anything about the show, you know the name of a show and they go, wow, he knows. He's like me. And then they can tell you all about it. Like, hey, what's your favorite one? Why?
You're saying I have an excuse to watch cartoons. This is for my job. I gotta watch cartoons.
Yeah, so when I was at Choa, you know, we tried to put on football, but, you know, it always get changed to Disney Junior or whatever. So.
That's our homework.
Nick Kids, I don't remember the names, but yeah, we watched those with them. I don't know why you wouldn't use an adhesive bandage to cover an injection site on anybody, but do it for them. This one, begin at the feet, move to the head. Easily distracted, go ahead, throw something on the iPhone or whatever so that they can watch with it. If they want to interact in the exam, let them do it, you know? You're kind of on their timetable. If these patients, any of these patients, are unstable and critical in nature, all that stuff goes right out the window.
Yep.
We get into resuscitation. You say, hey mom, I'm sorry, your kid's really sick. Take that baby away.
Give me the baby.
Yeah. A little sick, you know, there's big sick, there's little sick. If they're a little sick, allow them to stay with the caregiver, try to do your assessment from a distance, and then you'll get closer to them as they allow. Our school age kids, so they're starting to become little adults. There's definitely, you know, things that they have not yet experienced and concepts that they don't quite understand yet because they aren't adults yet. They are starting to understand the world and their place in it. You know, they understand family structure or, you know, a class at school, that they're part of a whole. This is when, yeah, you do get to involve them more so in the exam. You say, hey, do you want to hold on to the stethoscope? You put it right there. That kind of involves them a little bit. It gives them a sense of ownership so that it's not something that's being done to them. It's something that they are participating in. You can give them choices. You say, I have to give you a shot. Do you want it in your left arm or your right arm? Not getting the shot is not an option, but giving them the option allows them to have a sense of control over what's happening. So it's, again, not happening to them, but they are participating in this.
Your favorite truck, do you want to take this to the hospital with us?
Mm-hmm. Yeah, so yes and no questions are going to be the easiest kind. Let's see.
So I have a question.
Go ahead.
Whenever you're dealing with a sick kid who the parent is a juvenile, are you talking to the sick kid's parent that is the juvenile, or are you talking to
Depends on who the primary caregiver is. So if I've got a 16-year-old who has a newborn, but grandma is 47, who watches the kid most of the time while the 16-year-old is at high school, I'm probably going to ask the primary caregiver, grandma.
Okay.
Whoever has the information, I want to hear it. So I'm not going to like neg anything. I'm just like, well, you know, who has the most information, I'm going to gravitate towards them. And then if whoever else wants to chime in, I'm happy to hear it.
Yeah, good question.
So adolescents, you're indestructible, risk-taking increases, you've got these issues with psychosocial norms and trying to fit in, etc. You guys remember being a teenager, it sucks. So, you really want to protect their modesty, especially when it comes to issues of sexuality, sexual history, stuff like that. And additionally with psychological stuff, kids are under amazing amounts of pressure these days. And there's just not enough psychotherapy and places for them to go. So they come to us in crisis quite frequently, either after a suicide attempt or a suicide threat. Take all suicide threats realistically, report to the receiving clinician what they've said and what they have done, any kind of evidence you may see, like empty pill bottles or liquor bottles. Let them know kind of what that scene was like. Sometimes you may have to separate that patient from the caregiver, mom, dad, grandma, whoever, so you can elicit an accurate response from them. They often don't want to tell everybody the full truth. That's hard, so you gotta be truthful to yourself too. There are things you want to hide from your caregivers.
Yeah, we're kind of in the age group where we're concealing injuries.
When we are talking about these kids, it kind of falls into that OB-GYN situation we talked about earlier with sex trafficking. Things to look for sex trafficking would be a younger individual with an older, overbearing, usually male, tattoos for somebody who is younger than should be having tattoos. Things such as male's name that is on their neck, or inappropriately dressed, like dressing too old for their age. It's a 13-year-old, they're wearing a tube top and a mini skirt to the hospital. It's a little odd. Allow them choices. These are not the ones where you have to say, okay, it's going to be in the left arm or the right arm.
With that age group, if you're treating someone that falls within that age group for something like bulimia, are you treating that as a medical case or as a psych case?
Both.
Okay.
You can have a physical presentation of that issue. So with bulimia, I'd be worried about, they're constantly throwing up, right? So they may have what they call Mallory-Weiss tear, which is their esophagus gets eroded away by all the stomach acid. Yep. So Karen Carpenter, who was a pop singer in the 70s, she died from that because she had both anorexia and bulimia, and she would constantly make herself vomit, and she ended up having that Mallory-Weiss tear.
So what kind of facility are you going to go to, or what
Kids facility. CHOA.
Gotcha.
That's the easiest answer for most of these patients because they have, they're used to dealing with those. So actually Scottish Rite has a eating disorder floor for inpatient.
Gotcha.
So we have taken patients from Eggleston over to Scottish Rite for rehab. And then they teach them the psychology behind it. They monitor their calorie intakes, their exercise, all that kind of stuff to kind of get them on the right road.
Gotcha.
So, if you have that option of the EMT of the same gender doing the exam, it's beneficial. It's not necessary. It all depends on the comfort of the patient. Risk-taking behaviors right there. Here we are talking about, you may not be comfortable talking about certain subjects in front of caregivers. Try and get them not isolated, but, private.
I just say, I've taught a lot, and kids, even teenage 16, 17-year-old boys, their emotional state will flip in an instant. They will seem totally cool, totally tough, totally whatever, and something will happen that will trigger them or whatever. And they will just break out in tears.
Yeah. So gender norms, you can't assume one thing versus another. So this is the bread and butter of peds. Like I was saying earlier, is that they're most likely to go into cardiac arrest due to a respiratory distress arrest situation. The airway of a pediatric patient is a little bit different. We kind of touched on that briefly, that their epiglottis is a little bit more floppy, their trachea is going to be more anterior, towards the front of their neck. They got a huge occiput. So when you lay them supine, that's going to be something that could cause them to flex forward. So what we really want to do is we want to put padding underneath them so that then this can maintain a ear-to-sternal notch alignment. Gives you a nice airway. If you have to, BOS maneuvers, OPA, NPA, head tilt chin lift, jaw thrust. So with the little kids, obviously they have smaller tidal volume because they have smaller lungs. Their rib cage is more plastic, and their diaphragm is not as strong. So when they go into respiratory distress, they have less time to compensate than an adult would because they just don't have the muscles for it. Oh, they do have a larger tongue, so the space in their mouth won't be as large as you would for an adult. So, should you have to manipulate that airway, just anticipate that big fat tongue in the way. Not especially particular to us, but more so if you're doing advanced airway, this funnel shape of the upper airway, that's about the trachea, and it really affects with endotracheal tube size. So just something that if you're talking with an ALS provider, you can just chat with them about that. They are obligate nose breathers, but what are we going to suction first on a newborn? Then? Perfect. So they have a higher oxygen demand. Their metabolism is just at a higher set point than ours. So they're going to need more oxygen to get through that aerobic metabolism. Their stores and their safe apnea time is going to be lower because they have that smaller volume, lung volume, so that they don't have that reserve for period apnea. You're probably going to have to ventilate them if they have any kind of distress / arrest.
Would a cannula or non-urgent breather work best?
Depends on the child. Yep. So, and it depends on what kind of oxygen you need to deliver. So some of them like the mask better than the prongs. If you're going to put the prongs on them, I'd say put some tape on their cheeks to make sure that it stays in place. And then if they do need a mask, but they won't tolerate the full face mask because that can be a little bit constricting and suffocating to them, blow by, and just jack that flow meter all the way up to flush, which is 50 liters a minute. Just stick it right next to them, or have mom or dad or whoever stick next to them. So. It says watch out for the straps of the backboard. We're not strapping people down that tight. It's not restraints. This is spinal immobilization. So if you got them that tight, no. Dave's got some videos for us, so we're going to take a look at real quick.
Yeah, these are all things we need to watch out for. This is a peds respiratory doc talking to a room full of peds respiratory docs. But these are things you need to watch out for when you are assessing a child's respirations.
My name is Jessie Rankin. I work at St. David's Children's Hospital in the ER there. I'm a pediatric ER physician. I got the topic of pediatric respiratory distress, which is somewhat broad, but we're going to hit the highlights. And I called my brother-in-law before I started this presentation because he's a paramedic in LA County. And I said, so what would you want to know about pediatric respiratory distress? And he said, basically we want to know how not to F it up. So I said, that's so great. We have similar motivations. This is awesome. Okay, so in general, it's really important to just recognize what you see, right? I always teach residents like you should walk into a room and decide in like 5 seconds if that patient is sick or not sick, right? So you guys can do the same thing. It's not rocket science. So observe the child. What do they look like? Are they alert? Are they playful? Or are they completely responding to painful stimuli? Are they mad at you when you're poking them and prodding them? I like it when kids are crying and mad. A crying child is a child that's breathing, right? So remember that. This is what really scares me. Anytime you have a kid with respiratory issues and they are somnolent or they are their mental status is starting to kind of wane, you're in trouble. That's probably a sign of impending respiratory failure, okay? Okay, so different signs of respiratory distress. So your first sign you're going to see, and you're going to see this early on, is tachypnea, right? And it's just important to remember that kids in general will breathe at different rates, and there's different normals depending on how old they are. when you have these kiddos who are breathing really hard and fast, and then they start to breathe slow and they get more lethargic, that's when we're also heading into that danger zone. Okay, so, oh yeah, it worked. This is exciting. So retractions, right? So this is something you're going to see in kids. So they can retract in all kinds of different places, and sometimes where they're retracting can give you an idea of where they're having an obstruction, right? So babies are trying really hard to overcome this airway obstruction, no matter where it is. So they're generating really high negative intrathoracic pressures, and that's causing their soft tissue in their chest wall to kind of sink in. So that's what you see, right? In general, supraclavicular retractions or suprasternal tractions are kind of more of an indication of an upper airway obstruction, and then your intercostal and your subcostal retractions are in general more indicative of a lower airway obstruction, okay? So another thing that mostly just babies do is head bobbing, right? You guys seen this before? Yeah. So why do they do that? So they're just trying to generate more negative intrathoracic pressure to get more air in their lungs, right? Because they're obstructed. So contraction of their neck muscles is going on in order to assist ventilation. And since their neck extensor muscles aren't very developed yet, they're head bobs. So that's kind of what's going on. And they're just exhausted from breathing so hard. Nasal flaring. You've seen this a lot, I'm sure, too, right? So basically, they're just trying to decrease the airway resistance by opening up other airways bigger, right, to get more air in. So we'll see that a lot with infants as well. And like we said, the little ones, they tend to breathe through their nose more, so any level of obstruction in their nasopharynx is going to give them some difficulty. Tracheal tugging, I know you guys have all seen this, and this is what we're going to usually see in croup, right, or some kind of an upper airway obstruction. This is your suprasternal retractions. You just kind of see them sucking in right here above their sternum. You guys have seen this? This is the one I really don't like. Especially since 'tis the season, we're in the middle of RSV, right? So basically, these kids are trying to create their own PEEP. They're trying to create more positive end expiratory pressure when they're breathing out to open up those alveoli that are collapsing on expiration, right? So they're trying really hard to get air in and out. And this is kind of an ominous sign. And you're going to see this more in lower respiratory tract disease, like bronchiolitis, that kind of thing. You can also see how this kid is sitting, right? So kids are going to kind of tripod a lot when they're having an airway obstruction. They're just trying to align everything as much as they can to get the most air in. So you're going to see them kind of neck extended out and kind of leaning over a little bit, right? So that's pretty common as well. And then I know we've all heard this before, stridor, and you hear this a little better at the end of the video, but this is a high-pitched noise, right? You usually hear it on inspiration. You usually don't need a stethoscope to hear this, right? You can hear it from across the room. And this usually indicates narrowing in your upper airway. There's turbulent airflow going in because of that, and you hear this noise, okay? It can be inspiratory stridor, you can have expiratory stridor, you can have biphasic stridor, and that kind of helps you kind of judge the level of obstruction or where the obstruction is occurring, right? So upper airway obstructions, you're going to see nasal flaring usually, you're going to see stridor, you're going to see tracheal tugging, you're going to see stertor, okay? Lower air obstructions, this is where you're going to have more of your wheezing, you're going to have grunting, you're going to have subcostal and intercostal retractions, right?
Causing that, like anaphylaxis or
the pallor? Wait, no,
what's put them in that situation?
Oh, okay. So that's going to be obstruction of the airway. That's most likely from swelling, whether it be from croup or epiglottitis. So that's going to be like right above your vocal cords. That's swelling, and that's the noise of the air whooshing through there. So it's going to be infection.
What else do you see about him? Yeah.
Tracheal tugging.
He's trying to
create more
his lungs full by increasing that intrathoracic pressure so that he keeps his lungs open so that he ventilates better.
Yeah.
So,
Remember when we talked about COPD in elderly patients, pursed
Pursed lip breathing. That's
this
what this
is
kid's
the
doing.
infant equivalent of pursed lip breathing. Would you say this is big sick or approaching big sick? This,
He's getting there.
yeah.
And then I know we've all.
This is a sound that we need to be very aware of.
Yeah. And as the doc says here in a second, often you don't even need a stethoscope to hear it.
Yep.
You can hear it from across the room or over the idle of your Sprinter diesel turbo engine.
That is from your upper airway obstruction from swelling.
Is he in pain from the strike?
Yeah, he's probably in pain from the sore throat.
Yeah.
Yeah.
And how do we differentiate croup from epiglottitis from across the room? Which one has a seal bark cough? Croup. And what do epiglottitis kids do? Drool and drool. Yeah, absolutely. Good job.
Right here, you've got normal heart rates for kiddos. It's not set and fast. Depending on where you're at, they'll have different norms. Just get familiar with them if you can. If not, you have a tool that is in your first aid bag that can help you with that. Does anybody know what that is? It is a length-based resuscitation tape. So often called a Broslow. So what you can do is you bust that out, you put the foot at the kid, you go up to the head, you go, okay, there are purple, it shows you equipment, it shows you medications, it shows you normal vital signs. So that's a great resource if you're not comfortable with kiddos.
So is it harder to get Ross back on pediatrics than?
It depends on what the etiology of the arrest is.
Okay.
If it's straight respiratory, then those are pretty good. Chance that you're going to get them back.
Yeah, if you witness it and intervene quickly, yeah.
Yep.
Kids are resilient in that way, yeah. If it's a poisoning, there may be nothing you can do.
Yeah.
But good question.
Let's see. They got big heads. You're gonna hear it over and over again. Spinal cord injuries, less common, but like neck injuries, like a whiplash kind of situation can happen because they have less, their connective tissue isn't as tight. So.
Yeah, muscles aren't as strong, same reason they head bob when they're breathing.
This one is important, the abdominal part. So their organs compared to their size, they're much larger than adults. So like I said, they're the same as an adult with a little few changes. They've got the same parts, but their rib cage isn't fully developed, so that liver hangs a little low, that spleen hangs a little low. Those are highly vascular organs that could be injured easily in sports, off-road, motocross, ATV, anything like that. As far as their bones are concerned, they have not quite yet ossified the entire length of their bone. So what that means is they can have these things called green stick fractures. If you grab a branch off of a tree that is in full bloom and then you just kind of try to crack it, you'll see that it doesn't snap right away. That's what we call a green stick. So you've got the fracture, which we can obviously locate right here and right here, but right on the outside, it hasn't broken all the way through that outside channel. And so that would be our green stick fracture, kind of a splintering almost. That's very common in kiddos. They talk about like pain control and stuff like that. There's some of these kids that are tough as nails. They'll come in with an angulated forearm and it's literally like a big old square. I'm like, yeah, I'm good. Not even supporting it or anything. I'm like, do you want me to splint that? He's like, nah, man, I'm cool. It's like, all right, dude, whatever. So they can surprise you sometimes. When you get a fracture of the growth plate, that can cause a stunting of growth on that side. So say you fracture the growth plate of your right femur, that leg is probably going to be shorter than your left. So.
Will that heal over time?
I'm sorry?
Will that heal over time?
If you fracture the growth plate, there's a chance that it will be forever shortened. So.
Sorry, Chief, go ahead, Chief. With a green stick fracture, are you gonna try to reset that while you're splinting it, or are you just gonna splint it as it is?
The only time that we'll ever attempt a reduction in the field is if you have a disruption in PMS in that extremity.
Gotcha.
So your
A
pulse
green
motor
stick probably isn't
sensation,
gonna do that.
probably not,
Okay.
no. Even on that one that's got like this big old bump on it and looks gnarly as hell, if you can pinch on their fingernail and it goes back to pink, I'm happy. Hey buddy, can you feel this? Yep, okay, cool, leave it.
Okay.
Splint in the position found.
So what age does it not do the creek?
When you get into adolescence and everything starts to harden and become more adult-like. We're talking about infants. So we've got these fontanelles. Most easily palpable is this one in the front, and that's a great indicator for hydration status. So if they have a soft sunken fontanelle, you'll know that they are dry. If they have a bulging fontanelle, that's a problem as well. That could be signs of infection. It'll be quite apparent if you have a bulging fontanelle. The sunken fontanelle is a little bit more subtle. Whenever I have a patient, an infant or all the way up to toddler, I'm just like, oh, hey buddy, how we doing? I take just a little rub on their head so I can feel that soft spot. Don't push in hard. You just kind of realize where it's at and get the assessment on it. The fontanelles are because the skull hasn't fully formed yet. Like I was saying, the ribs are not fully formed. They are highly elastic and plastic. This one is a sunken fontanelle. You can see that right there. So the posterior fontanelle, like right here, it's really just a fingertip. That's all you're gonna feel. Whereas this anterior, you can probably feel 3, and then it starts to close over time, and every kid is different. So just because you've got an 8-month-old who has a closed anterior fontanelle doesn't mean that your next 8-month-old is gonna be closed as well.
What causes it to sink in like that, other than like somebody pushing on it?
No, they're dehydrated.
Dehydration, fluid status usually. Infection can cause that, you know, if they have extrinsic losses through an increased respiratory rate, or they're not taking fluids in and they're, vomiting and diarrheaing and out.
And nausea, vomiting, diarrhea, and what kind of shock are we leading up to then? Hypovolemic, that's right.
Keep kids warm. They just don't have that same mechanism that we do. They have less brown fat, they have more yellow fat than we do. Brown fat is the insulation kind. If you are on the way to a call, go ahead and bust out your pediatric tape or your hand Tevi app, or whatever resources you have. Go ahead and open that up. If it's just the Tough book that has all our protocols on it, go ahead. Hey, you know what? I'm going to an anaphylaxis of a 7-year-old. I wonder how much epi I'm going to give them, or anything like that. Okay, that's not cheating. That's using your resources. Pediatric assessment triangle. This is going to be our big thing to do with pediatrics. We look at appearance, breathing, and then circulation. Appearance is going to be that from the doorway. Are they sick? Yes or no? Are they big sick or are they little sick? Then we do our work of breathing, which is pretty obvious. We're talking about all those things that we just looked at, work of breathing, intercostal retraction, subcostal, all that stuff. Auditory noises, which may be abnormal. And then skin circulation. Are they pale? Are they mild? These are all things that you can assess from a distance. Once you get more comfortable with it, it just becomes second nature. They like this tickles mnemonic. If it works for you, it works for you. We're going to be looking at age-appropriate interactions too. So if you've got, your toddler who then hides behind mom, that's totally appropriate. He's not looking at you. He's not, interacting with you, but that's totally age-appropriate for that individual. Work of breathing, we've covered with the abnormalities. And then circulation, what we're going to talk about is the color, as in pale, pink, and pale being specific to that individual skin tone, pink being to that individual skin tone. You can tell somebody, even if they're pushing the color, that their color is off. Modeling, let's see if I've got it. Yeah, so it's kind of like that speckly color right there on my forearm. But that would be a sign of poor perfusion. That means that all the blood is shunting to that individual's core. So it's coming away from the periphery. It's prioritizing your main organs. Cyanosis is big sick. That's going to be that bluish hue to their lips, around their mouth, their fingernails, things of that nature. Another place you can look when it says pallor of skin and mucous membranes. So for me, it is a little bit more difficult to tell somebody's color if they are a person of color. What you can do is you can look at the mucosa of their eyes, because that should be pink in everyone. You can look at their gums. That will be an indicator of whether they have good color or not. This is stable, unstable, sick, big sick, you know, not sick. You get all that in your PAT. You got your XADCs, that's when you do your hands-on portion of your primary assessment. It's the same as for adults. If their airway is patent, just let them take care of it themselves, especially for croup epiglottitis. Try not to piss them off, because that will cause increased swelling, which will worsen their upper airway obstruction. So you let them maintain a position of comfort, let them roll. I will say, however, do not allow your child to ride in mom's lap on a stretcher. That is not an appropriate way to transport a pediatric patient. We have specific ways to secure them, multiple ways. We've got the Peavy on some of our ambulances still. We've got that, whatever, the
ACR.
Yeah, that thing. Whole bunch of straps and Velcro, practice putting it on.
Yeah, the beach ball.
And then...
even if you're good at it, it
yeah.
takes 5 to 10 minutes.
Yep. And then if you must, you can transport them in their own car seat, but it has to be rear facing. I prefer not to, because I have specific things. I don't know the way that your car seat works. I know how my ambulance stuff works. So that's my preferred method of transporting a child. Additionally, if all of a sudden things go south and I have to emergently manage an airway, do I want to try and tip a car seat backwards, or do I just want to lay the head of the stretcher down and be able to suction work as I need to?
What about the captain's chair?
That is okay for stable patients.
Yep.
You know, if I've got a brother-sister combo, something like that, and they're just tagging along, yep, you're going in the captain's chair. And they have to be the appropriate size. Yeah.
When you have a big sick kid, are you letting parent ride with you, or are you telling them to follow?
So it really depends. It's case dependent. If there are 2 caregivers, I say one of them, you'll meet us up there in your car so that you have a way home, and then I'll let one of them ride up front.
Yeah, up
Even
front.
if you're
I do not want them in my area because they will freak out.
Yeah.
Because if I am having to do work on their child, they are going to freak the F out, and I've got 2 people now.
Yeah. And you've usually got a firefighter or another crew member. The Sprinter's tight enough, even with pediatric case, with 2 providers in the back. Yeah, sick kids, parents can ride, but up front.
Look, listen, feel for breathing. If they're unresponsive, go ahead. Put your head next to their airway, put your hand on their chest, and then you're checking for all the normal things that we check for. Belly breathing is totally normal for kiddos up to a certain age because they don't have that really strong diaphragm yet. Bradypnea, that is a pucker factor kind of moment.
Impending arrest.
Yeah, you want to ventilate that child. You don't want them to get to any respiratory rate lower than 12.
Yeah.
Like, I would be concerned if it was in the 16-ish range and they were under 7 years old.
When we were watching the videos, work of breathing, I said it's not going to last very long. Well, that's when it winds down.
Mm-hmm. So kids, they will compensate until they don't. And they fall off that cliff real quick. Yeah, they will decomp on you like nobody's business. They will climb that mountain, and then all of a sudden they fall off the cliff. And you're better to try and catch them here on that precipice than over here. Circulation, brachial, femoral, on older kids, radial's fine. When we're talking about CRTs, cap refill time, anything over 2 to 3 seconds is delayed. The way that you'll check cap refill, super simple. You just take it, pinch, and then you'll just wait for that to turn back to pink. People of color, you go on their fingernail, same situation. Anybody, you can go on their fingernail, but I like it because you can do peripheral here, and then you can check central here as well. Skin temperature, color condition. If you've got somebody who is not acting appropriately, then you'll do like a neuro check, pupils, glucose, all the regulars. Try to keep them warm. If you are uncomfortable in the back of the truck because you have the heater on, then they probably are comfortable. If you have a patient who has had an exposure to the environment, go ahead, heat up the back of your truck. You know, if you sweat for 13 minutes, but it helps them get an IV at the hospital because they are warm and not shunting, you did your job. Sucks to be a little sweaty, but that's what it is. Questions about that stuff? Cool. This is another one, benefits of ALS treatment in the field. So that comes down to, again, this is that decision tree. How far am I from a pediatric ED? Do they need to go to Big CHOA, or can they go to WellStar Peds ED? How long is it going to take for ALS to get here versus us getting to the appropriate destination? These are all things that you have to do critical thinking with. This is the one where it talks about using the car seat. You guys know my feelings on that.
If I can jump in real quick, that is the reason we have the ACR. The PD mate was not rated for, I don't
anybody
recall.
over 40 pounds. With the ACR, you can go newborn all the way up to 100 pounds.
So I know WellStar Keystone has a pediatric.
Yeah, they've got a PZD, and COT has a PZD.
Yeah.
They have a limited inpatient unit for pediatrics. So when I worked transport for CHO, we would kind of scoop up kids and bring them back to our hospital. So,
in fact,
if it's something simple like, hey, you know what, they got an upper respiratory infection where they may need IV antibiotics, completely appropriate. Go to Keystone ED, or they need sutures, simple stuff. But if they're big sick, you probably want to go to CHO.
Yeah, am I still correct in that the Peds ED at Keystone at least was staffed by CHOA docs?
Yep.
Yeah.
Staffed by the Scottish Rite Pediatric Emergency Management Group. The fact is that they have one helicopter, right? It's located over by Peavy Airport. So for them to get to you is going to take an extended time versus a helicopter that's in that general vicinity. Granted, the people that are in that general vicinity on the helicopter are not pediatric specialists. However, they can get you to a pediatric center a lot quicker than a ground truck. And they do have more training on peds than your typical ground crew. Kids in arrest don't use the patient's car seat. So this is what I was talking about. Why would you wait until they're in arrest and then try to switch them into an ACR or something? Just put them in the ACR if they're sick at all. I just don't like the car seat situation.
Agreed.
Make sure that they are secure for transport. Never, 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 never in mom's lap. Most of the time you get history from caregiver. If they're older, the patient can give you history. The one big thing that is going to be big is this eating, drinking, urine output.
Yeah.
So for these kiddos who are nonverbal, whether it be, you know, they're young or they have a developmental delay and they can't report to you, ask the caregiver, hey, how many wet diapers do they usually have? Are they making the same number of wet diapers? Do they have decreased urine output? That's a problem. You know, hey, are they taking their bottle, or have they eaten as much in the last couple days? Oh, no, it's reduced? Okay. So we couple that with, hey, you know what? You've got gastro symptoms of vomiting, diarrhea. They're not taking in fluids or foods, and they've had fever for a couple days. It's probably a sick kid. They probably need to go somewhere.
And if your caregiver who presents themselves as the primary caregiver, does not know the answer to those questions, or your index of suspicion for neglect is going up.
Yeah. Kids are dirty, you know, if their environment is in poor repair. You know, those are ideas of either neglect or abuse. There you are. So bowel or bladder habit changes, vomiting, diarrhea, abdominal pain. Those are very common symptoms for kids. Undifferentiated abdominal pain needs a referral to a hospital so that they can figure out what's going on. There's a lot of things that are in there that could be wrong. Get the name and phone number if you can, and provide that to the receiving facility. because there are times when we do have to separate caregiver and patient. You know, hey, they've got one car, so they're gonna drive down to meet you there or something like that. So go ahead and get that number for your benefit and for their benefit. Nasal congestion in little kiddos can often be a sign of respiratory distress. And if you give them a little gentle suction, maybe some lavage, you know, a little saline drop or two, suck some stuff out, they're gonna be breathing so much better. It's amazing how much like that can provide relief. Nobody really looks inside of ears, so but if you notice that they are red or they're tugging at them, just something to realize. If they got some weird, funky smell to their breath, something to be aware of. They may have dental caries or abscess or something like that, just from poor hygiene. They can't move their neck and have a high fever. What would we possibly be concerned for? You got it. Yep.
Awesome.
So if you cannot flex their head forward, then yep, meningitis. Another one is if you try to raise their knees to their chest and they won't let you do that, that's going to be another sign.
Would that be immediate, like, ride to Choa?
That would be a ride to Choa. It wouldn't be an emergent unless they started to become altered. But that's somebody that you have a high index of suspicion on, and you're looking out for changes in your physical exam. The only thing that's going to help them is going to be antibiotics, which none of us carry. So, abdomen, that's going to be one of your big things. A lot of signs. Again, look at your Roslow tape. They say blood pressure is not very useful in this patient population. I'm going to disagree with that one as well.
Agreed.
Because we can do a blood pressure even on like a 22-day-old. Okay, and it can give me information.
And do we remember normal systolic for peds? Remember what that formula is?
Oh, times 4 minus 7.
Yes. Awesome, Miss Boucher. Yeah. 70 plus age X2.
And that's age in years, so
Yeah.
you have to be at least 1 year old for that to work.
Yeah.
But yeah, if you have the equipment to use, go ahead and use it. You know, if you've got that small blood pressure cuff that'll fit on somebody's arm or on their calf, yeah, go ahead. You have to have a cooperative patient. Sometimes you just hold their legs still and straight so that you can actually get that good pressure on them. Respiration for 30 seconds, if you want to. I like 15 seconds times 4. It's a lot quicker. And then you can do their heart rate for 15 seconds. 30 seconds you have respiration, then heart rate. Unless it's abnormal. If it's abnormal, then you're going to need to do like a full 30 seconds or a full minute. 30 seconds for the respirations and a minute for heart rate. Same things, stable 15 minutes, unstable 5.
Do we hook a life pack or cardiac monitor up to like that?
Yep, you have a cuff that goes all the way down to about like a 1-year-old, 18. Air obstruction, toys, candies, whatever.
Airway obstructions come in 2 flavors. They are, yeah, that's what I was going to
Oh, okay. Listen where you can on these kids. If mom is holding baby this way, go ahead, listen to the back. You know what? That's what's available to you. Go ahead, listen to it. And you can sneak up on the kid. They won't notice that you're there. They may startle when you put that cold stethoscope on them, but this is a great way to get an assessment on their respiratory status.
And if the kid's startling, is that a good thing or a bad thing? That's age appropriate, yeah.
Totally appropriate response
Good
for that
thing.
age kid. Hind leg CPR if necessary. These are the indications of obstruction. No blind finger sweeps, only if you can see the obstruction should you sweep. Bronchiolitis is one of those ones where they're just pouring junk from their face. It's a respiratory syncytial virus, and it's easily passed around at daycare and school and stuff like that. So because they are so little, that's where the problem comes in, because they have these little airways that they get clogged up with junk. Humidified oxygen, oxygen in general, some suction, those are going to be your mainstays of treatment for those kiddos. Asthma is a swelling of the airways. It can be due to a couple of different factors. If they have albuterol at home, encourage them to take it, transport, and position of comfort. Pneumonia, this is a secondary infection often caused by URI, upper respiratory infection, or from a chemical ingestion, caustic ingestion. So there are kids who might be on immunosuppressants due to cancer or due to other disease processes that puts them at increased risk for pneumonia. You may find a chronic kid who is on prophylactic antibiotic. So like your kids with cystic fibrosis, they may be on an antibiotic as a regular treatment for them. The diagnosis is going to be a chest x-ray at the hospital. You may hear crackles or rails in that affected area where the pneumonia is localized. So yeah, unilateral crackles or rails is going to be your hallmark for pneumonia. Croup, we talked about, it's swelling the upper airway, humidified oxygen. If they give you a history of, well, you know what, I took them outside, it was, and it's a nice cool night, and that helps the sound, then you nail the diagnosis for croup. Because when you get humidified, cool air, which reduces the swelling of that upper airway, bam, croup. Additionally, it's a very distinct sound. Humidified oxygen can help these kids. Epiglottitis, bacterial infection, it is very dangerous because of the swelling of that epiglottis. So should they have full obstruction of that airway, it's going to be difficult to treat for even the most skilled anesthesiologists in pediatrics. So we don't want to mess with them. Let them do their thing. You can stay 18 feet away from them. They usually look real sick. Bronchiolitis is RSV typically. Viral in nature, no antibiotics will help it. Pertussis, it's thankfully been mostly knocked out due to vaccinations in most first world countries. You get this, it's also called whooping cough because of the distinctive sound of the cough that is made. We get vaccinated for it with our Tdap, tetanus, diphtheria, and pertussis. That is your typical vaccination for it. Proper PPE on all this respiratory stuff, you know. Goggles, gloves, N95. Pediatric BVM or infant, the bag, like the actual squeeze part, is about this big. It's the size of a lemon. It's 2 fingers. Nice little gentle pulse on that. That'll be up to about like 2 months-ish. Then you'll move on to the pediatric bag, which is yay big, small, like Nerf football size. Then from about adolescence, you're gonna go on to the adult bag. NPAs, if you need it in somebody who's less than 1 year old, you're probably just gonna move on to an OPA. We do have the teeny tiny OPAs though. So if you got somebody who is obtunded and you need an oral airway, go ahead and place it and then skedaddle on to CHOA. Very vascular up in the nose, so that's why we don't use them in the little kids. There's a condition called choanal atresia where you can't pass something through one side of the nose. So these kids have that until they get it corrected, which is usually done in the first couple of years of life. So if you do have that young toddler or so, and you try to pass it through one there, and you're not able to, just try the other side. Blow-by, cannula, non-rebreather, BVM. So escalating FiO2 that you can get. There you are, so less than 12, greater than 60, you're gonna assist ventilations. This whole cup situation is dumb. I don't know anybody who's ever done it. If you really need to, you can do it, but I don't know anybody who has. You just use a non-rebreather mask and put it close to them. Cannula we know about. You see that cup, you see the cannula, but give them a hose if they need it. BVM, slow, gentle squeeze. Make sure that there's good mask seal. If you need to, use 2 people to provide BVM. We're going back to CPR, cardiopulmonary arrest, most often because of respiratory arrest or respiratory compromise. Most often from dehydration due to GE problems, huge infection, neurologic problems. These are going to be rare. You may have this diseases of the heart for like a congenital heart defect, but that's going to be an ALS call. They probably wouldn't send you guys on that one. heart trouble, whatever, it's going to be painless. So they will increase their heart rate and respiratory rate to compensate until they don't. So if you do have cardiac arrest, imminent, compressions airway breathing for them. Anaphylaxis is distributive shock. It's because their vessels have gotten large due to histamine release. Say it's the same thing as adults.
Just weight-based med dosages.
Yep.
Yeah.
Hemophilia, it's X factor related, so it's going to be predominant in males. Women can pass it on. What they need is factor, clotting factor. So a lot of times they have it at their house, and then other times they need to go to the hospital for it. AMS, AEIU tips. Seizures. The important thing, like we were talking earlier, put them on their side, make sure they don't hurt themselves, give them oxygen if they need it. There are your causes of seizures. And febrile seizure is going to be one that's very concerning for the caregiver, but we know that typically it's just because of the high increase in fever. It's not the height of the fever, it's the rapid increase or decrease in the fever that causes the seizure.
Yeah.
Status epilepticus, where you don't have a break in your seizures or they recur. So if you have any kind of device in you, so say you have hydrocephalus and they put a shunt in to drain some of that fluid, then you have an increased risk of getting meningitis, something getting into that device and then cultivating. You can see this meningitic rash sometimes, not always. GE emergencies, most of the time it's not an emergency, it's an urgency where they need treatment, but it's not life-threatening. Sometimes it can be if it's been going on for days and days and days, not been treated. Are they producing tears? That's a good assessment in addition to the wet diaper situation. There are certain things that kids can get into that are dangerous, as those are listed. Call poison control. They're your expert on that stuff. They're happy to hear from us as 911 providers. I talked to them once on Benadryl overdose, and they said, oh, they're hyper right now? Cool. How many cats were in the purse? How many children were there? Okay, the LD50 is called lethal dose 50, so that means that 50% of the population will die if they take that dose. They said that LD50 for the youngest child would have been like 3 packages of that Benadryl. So those kids are fine. They don't need to come to the hospital. I said, great, that's exactly what I wanted to hear. I didn't want to take all 3 of them in with me. Mom didn't want them to go either, so I was just covering my butt. Because they have a doctor 24/7. They are a toxicologist. I put it on them. Bump it up the chain. You got some signs of dehydration right there. Touched on those a little bit about Vaginal. Skin parameters. There you are. That's a fun one. Tension or poor skin turgor. Fevers are rarely life-threatening. They are concerning to the caregiver. Give them some Tylenol, some Motrin, they'll be all better. Typically. If they have continued fever for multiple days, that's when we need to go into the hospital. Temperature in these kids, axillary is appropriate. Know that they will typically read 1 degree C less than a core temp. If you need a core temp, rectal is the best way to get it. This is what I'm talking about with the falling off the curve, falling off the mountain. They will lose over 75% of their entire blood volume before they show significant decomp. Whereas an adult, it's 50, 60, somewhere in that range. So 75%?
Yeah.
Yeah.
Yeah, that's why we always say hypotension is the hallmark in adults. If you're waiting for hypotension in the kid,
you missed the boat.
Yeah, you're done.
Burns, go to a burn center. Cho is not one of them. Cobb is a burn center. So if you don't want to drive all the way to the city of Grady, that's an option. Okay, child abuse and neglect. If it seems off, report it to somebody. It's all about context clues, making sure that we can evaluate the scene appropriately and report that scene accurately. SIDS, there's not much you can do about that. Death notification is that, hey, your child has died. That's the situation.
Why do you do it so blunt?
What?
Why do you do it so blunt?
Why are you not helping my kid?
Are you going to sugarcoat it?
Why are you not helping my kid?
I mean,
Why are you not helping my kid? Well, do something.
There is nothing else.
Do
that can be
something.
done.
Why are you not
Your
doing
child
anything?
has died.
Yeah.
I'm sorry.
That's not what I mean, but like you said earlier, you don't say your kid passed away, you just tell them.
Because that gives them a false sense of security or a false hope. They say, oh, they've gone to a better place. Oh, what is that better place?
Because this is the response you're going to get.
Yeah.
That's the response you're going to get to that type of answer.
Yep. And so it's like, yep, they're gone. There's nothing more to do. I always offer before I leave the scene, I give them a full update of what's going on. I said, hey, the coroner has been called. This police officer, deputy so-and-so will be here until they arrive. Is there anyone I can call for you? Is there anything you need right now before we leave?
Yeah. Even if the child is cold, stiff, and blue, why are you not doing something to help my kid? Is the response you're going to get.